of SCOT, and welcome to you all to this Summer SCOT webinar. It's obviously a slightly different format from the one we are used to, but I'm delighted that we've had almost 120 people sign up for today's meeting, which I think reflects great support for the event. We were very keen to host something to mark Summer SCOT, and it's great to have that support. Not just for discussion of some really important things that have obviously been happening since we last met at the end of January, which seems like a lifetime ago to all of us, I'm sure, but also to support our trainees and all the work they've been doing and give them a chance to present their work this afternoon. So I'd like to encourage everyone, please, to, if they can, stay on for the registrar presentations later on today. There's also posters for trainees, and we've put the posters on the SCOT website. And again, please do go and take a look at those posters, which are very informative and reflect some excellent work. As I said, we're very lucky today. We've got three excellent speakers lined up for you, and I'd like to thank each of them and express my thanks for you giving up your time to join us and present what I think might be maybe some slightly different perspectives on the COVID era and how it's affected yourselves, your practices, and where we go from here. We'd normally, of course, would have enjoyed welcoming you in person and offering you some hospitality, but I'm afraid we'll have to offer you that in the future and hope you can take up that offer another time. Before we start, though, I'm going to a couple of words just to summarize where we are and how things are. And of course, it's been a very disruptive time for the last 6 months. I think that's perhaps an underestimate. Within 2 months of our last meeting in January, almost all our elective activity had, of course, pretty much stopped, and we were all reconfiguring our trauma services to try and ensure we could provide a trauma service that was safe and robust for what was a very uncertain time. I think what I'd like to say, though, is that it was really quite very impressive to see the response of the Scottish orthopaedic community at that time, and to see the way that the orthopaedic community came together to share ideas, to share knowledge. There was so much going around at the time, so many different pieces of information emerging. And also to share our concerns. There was naturally a lot of anxiety about where we stood in terms of protecting ourselves, our patients, and our families. And it was truly heartwarming to see the communication that developed between us all. And I think it's brought all the units closer together. And that benefit is continuing with our communication as we face newer challenges of trying to restore our elective practices. It's been a privilege to be part of that and to see the robustness and versatility of our colleagues. Another truly impressive development which deserves mention is the research and audits which kicked into action early on, and special mention to the impact team in particular, who created and ran a study starting in Scotland but expanding to include about 100 hospitals, I think it was, 16 different countries, 5 or 6 continents, of multinational collaboration on collecting information on how COVID was affecting our orthopaedic patients, and producing some really valuable early information how COVID related to our hip fracture patients, and then also our elective patients, which was very useful for us to inform our board leaders and Scottish Government on the risks, the potential risks of COVID and our elective restart. That work continues. There's more emerging, and we look forward to more information from the impact team and many others who worked hard on that. I think fair to say that the UK can hold its head up high in terms of the research that's been done during COVID. And I noticed that was acknowledged internationally recently. We obviously face a huge challenge, as I said, with our elective restarts. And to give you an idea of the scale of the problem, in March we had about 8,000 patients waiting over 12 weeks for an outpatient appointment in orthopaedics. We now have over 20,000. And it's a similar picture in terms of our inpatient waiting list. We had about 9,000 waiting in March. 9,000, and that number is creeping up. And perhaps the most worrying part is that half of that number, 10,000 patients, are waiting more than 6 months for surgery, and many of those have waited a year now. So there are a lot of people out there in significant need. We've seen them deteriorating on our waiting lists, and we all have an anxiety to try and get them back into the system and treated as quickly and as safely as we possibly can. Those numbers have crept up despite the fact that the referrals coming into our service have really diminished enormously, and we're still not back to anywhere near our normal rate of referral into our services. So we have to anticipate that that is going to start increasing and the problem becoming more acute. One thing I think we can do is to share good practice, as I've said already, between units to help some units which are finding it harder to implement newer processes, such as virtual consultations, advanced vetting, and others. It's interesting listening to the regional reports over the last few months and this morning's SCOT committee meeting to hear about the variation that exists. And I have a slide I can show you if I can just share the screen on what's happening with our outpatient waiting lists, which is quite informative. As usual, we have to bear with the technology to sharing the slide. But I wonder if you can see that slide. I can see, Daniel, can you nod if you can see that picture, that graph? And then I can, yeah. So there are no names attached to this in terms of boards, but each line represents a health board in Scotland. And you can see this is the new orthopaedic outpatient waiting list and what's happened between March, and these figures for the end of June, but actually the graph continues much as it has through to August. And what it shows us is this variation. It's not to point a finger of blame. It's not to suggest that there's any particular fault. It just shows you that in some situations, boards have managed to reduce their outpatient waiting list dramatically, and others have seen almost the opposite. And I only show you this graph to highlight where the variation is, and that we need to understand why that is happening, so that the boards that have had success can share why they've had that success with those that are finding it harder. And a lot of this is modernization in terms of enhanced vetting practices, remote consultation, adoption of remote consultation early on. I think I understand that obviously there's quite a variation in how people feel about some of the newer practices in remote consultation, but it's here to stay. And I think one of the most important things to appreciate what our patients feel about it. And feedback from recent survey by Versus Arthritis, for example, reported that patient satisfaction with remote consultation is high and is actually something that they wish to see continue. So we have to adopt it. We have to understand better when it works best and embed it in our practices going forward. The other thing, when I'm talking about variation, which I'll be very interested to hear, particularly from Phil about this in due course, is the approach that we're seeing from our individual health boards. In Scotland, there has been a lot of autonomy given to our health boards for their recovery, and that seems to be leading to a situation where some health boards are now approaching 80% or more of their normal elective activity, whereas others, and I include my own, are sitting at 20 to 25%, with a worrying feeling of no great improvement in that to come for the next month or two. And whilst we appreciate that our health boards are still on an emergency footing and have been mandated by the government to be ready to step up to deal with COVID surges, it doesn't seem logical that there should be such variation between our boards, often geographically beside each other, in terms of how they are responding and providing elective services again. And I mentioned England because we've been watching closely and seeing communications from NHS England, and they seem to be taking a more uniform and perhaps tougher line, perhaps Phil would agree, in mandating targets for recovery of elective services with ambitious targets of resumption of 90% plus by the end of October, but also using a tool that you have that we don't, which is financial penalties or financial incentives, perhaps is a better way to achieve those targets. And it's something we're watching from Scotland, perhaps with a slightly envious eye. It'll be interesting to hear from Jason Leitch this afternoon. I'm sure there'll be questions put to Jason about this and the approach we have here in Scotland. I'd like to, before we go on, make special mention of training. One of Scott's remits is to support training, and we, again, there was a very successful Trainees Day yesterday, and Tom, our BOTA rep, deserves praise for organising that in its new format and getting everyone together and delivering a valuable day. So many thanks for all the work and all those supported that event yesterday. We've obviously seen training change. Teaching has perhaps flourished in some cases with teaching and a lot of work being put in by trainees and faculty to produce some excellent online product. But of course, where we are anxious and where trainees are naturally anxious is the loss of operative opportunities and skills training. There's really no substitute for that, but to try and restore as much operative activity as we can, as well as simulation. What I would like to make certain people understand is that wherever operative opportunities appear, please do maximise them for your trainees. Private sector was procured by the NHS in Scotland early on in COVID, and there's still a lot of activity, NHS activity there. And NES has achieved approval for all of those sites with the GMC for training. There were also some concerns about indemnity of trainees working in the private sector. Those issues have been resolved by NES, so there shouldn't be any barriers to taking your trainees with you to any operative opportunities that are arising at the moment. So if there are, please convey them through your TPDs, take them back, we'll take them back to NES and deal with those problems. I think also, before I finish, I would like to just single out the trainees for some particular praise. It's been hard on all of us this last 6 months, and as consultants, we've seen significant disruption, but our trainees were often in the forefront of that, and particularly our most junior trainees who found themselves redeployed to environments they did not expect to be in or perhaps choose to be in. And I think across the board responded extremely well and admirably, and they deserve our praise and support for really stepping up to the mark. So from SCOT to all of our trainees, well done. Thank you for everything you've done. And we now owe it to you to get you back and train you and turn you into the orthopaedic surgeons that you wish to be. So that's all I wanted to say, and I'd like to move on to today's program. The format will be that, and many are familiar with the webinar format now, that each of our 3 speakers will present for around 20 minutes. And during their presentation, you can submit questions on the Q&A comments tab. Nick, our secretary, will collate those and put the questions to our speakers at the end of their talks. And we'll convene some discussion, hopefully, for each speaker. It's my pleasure now to introduce the speakers. I'll introduce each speaker just ahead of their own talk, if that is okay. And our first speaker today is Professor Daniel Porter. I know Daniel well from our time in Edinburgh together. Daniel moved to Beijing now. Was it 2015, Daniel, or was it before then? To take up a professor.
2014.
2014. To take up a post as Professor of Orthopaedic Surgery at the First Hospital of Tsinghua University in Beijing. And Daniel, you've agreed to give us an account of your experiences of COVID and your perspective from China. And I very much look forward to hearing from you. So thank you very much.
Thank you, Alistair. So I can start now. I think Paul will share the slides, Paul Jenkins. So thank you, Alistair, Paul, and your colleagues on the SCOT committee for giving me this opportunity to present to you what we have experienced here in Beijing. If there are any lessons or applications, it's not for me to suggest what they are, it's for you to see what they might be, because our situation here in Beijing is so very different from what you have in Scotland. The culture is different, the hospital system is different, the governmental system is very different. So whatever we've been able to achieve here cannot be directly applied, but must be filtered to have any relevance. But I would like to share what we've been doing. So next slide, please. First, some context. So I've been working in Beijing for more than 6 years now. Tsinghua University and its associated affiliated hospitals, one of the largest university systems in China, and one of the top university systems here. I work in the university, a public university, and the public hospital system, and I have no conflict of interest to declare as I give this talk. Thank you. Next slide, please. So again, the context now, what about Beijing? Beijing is a large city, 21 million people. It's swollen beyond that with migrant workers, but we have few migrant workers at the present time with the epidemic. Most medicine is delivered through the public system. The hospitals are controlled closely by the Ministry of Health, and we have a large number of comprehensive service hospitals in the city and a an even larger number which are providing more specialist care. The health system is insurance-based and competitive between hospitals, so quite different from the NHS environment. Next slide, please. Next slide, please. So this slide shows the current situation in Beijing. I took it from one of our websites, news websites, a couple of days ago, and it shows that there are now no patients, active patients in Beijing hospitals. You can see that Beijing has had less than 1,000 confirmed cases. I'm sure the number of cases is more than that, particularly in the early days when we were not classifying infected patients as having the disease, but they were just being quarantined until their symptoms had settled. But after that early phase, I think this is fairly reliable data. So we are in quite a different situation to what you're experiencing in Scotland even now. Next slide, please. So who is this fellow? I don't know if you would be able to identify him, but he is important. He's important in China, and he has relevance in Scotland too. Next slide, please. Zhong Nanshan got his MD in the respiratory unit at City Hospital in Edinburgh at the end of the 1970s. He was responsible for looking after the Chinese SARS epidemic more than 15 years ago now. Next slide, please. At the beginning of the current epidemic, it's worth saying that SARS took nearly 2 years, 18 months to clear from China. At the beginning of the current COVID epidemic, another coronavirus, he was placed in charge of the National Infectious Disease Committee in China and has guided the policies which I'm going to talk about. Next slide. So the timeline, which you'll be familiar with, is that the last day of 2019, the WHO was informed of the presence of a novel coronavirus. It took a while for this to become evident that it was spreading from person to person. And towards the middle and end of January, it became evident that it was spreading into other cities. Zhong Nanshan made a national broadcast just before the Spring Festival to alert the people of China that this was out of control in Wuhan and was spreading elsewhere. And he was tasked with announcing the 2-week quarantine policies, which are being used worldwide. Next slide, please. So what is home quarantine? I was sent these photographs by my registrar some weeks ago, who was quarantined himself. And if you are quarantined, then some local contact tracers will come to slap a notice on your apartment door, and you're not allowed out for the next 2 weeks, and food will be delivered and you have to stay inside. Next slide, please. So immediately the policy was one of hospital segregation. 3 hospitals were designated as infection hospitals in China, and to these sites, all definite COVID cases were sent, and all those who were likely to have it for isolation and or treatment. And all other hospitals and medical facilities were asked to stay clean. So this is a key slide, a key message that we all had to maintain. Next slide, please. So what about these 3 hospitals? They were situated in non-residential areas. They had existing respiratory disease expertise, negative pressure operating theatres, and capacity was predicated on likely case numbers over the following few weeks. Like you, building Nightingale hospitals and other hospitals for excess capacity, this was also done in Beijing and other cities. Next slide. So in the infectious hospitals, these 3 COVID hospitals, these would be the types of wards, small bays, isolated, and with only patients who are infected allowed to enter. Next slide, please. Well, my hospital quite different. It's a teaching hospital situated in a dense residential area, 850 beds, elective and emergency admissions with all major hospitals represented. And this is a photograph I took of our hospital a few days ago. Next slide, please. So we were designated, as most hospitals were, as clean hospitals. So all potentially infected patients were processed through a fever clinic. This is a photograph of the fever clinic. It's in a separate part of the hospital, away from the ward areas and emergency areas. Now there are 200 fever clinics in Beijing. They function 24 hours a day. And if you think you might have got COVID, then you have to go there. Next slide. So in the fever clinic, staff wear full protective gear. Screening tests are done here, and the risk of infection is assessed. Patients who are deemed or were deemed, now we have hardly any cases. Patients who were deemed at high probability of infection were transferred to one of those COVID hospitals. They were not allowed into our hospital or any clean hospital. Next slide, please. So beyond the fever clinic, the hospitals remained clean and functioned as a clean facility. Hospital staff knew what they had to do, and that was to keep out any patient who might be infected. All members of staff were expected to support this policy, and the wider community was aware of it. Next slide. Staff infection control was important, of course. Twice a day, we had to provide a symptom screen, give a history of where we'd been, and check our temperatures. Entering the main building required temperature checks, and this became increasingly sophisticated with time. Next slide. So this is the current situation through one of the entry points to the hospital. You have to socially distance and then walk past a guard. There is a facial recognition platform for Chinese citizens so that they can then have their own health data checked and ensure that they've not been out of the province or in contact with anybody who may be infected. For a foreigner like myself, I just have my temperature checked by the guard. I've got my own phone-based health kit, which tells the guard that I've not been out of Beijing actually for many months now. Next slide, please. So what about the clinic and ER areas? If a patient wanted to come to the clinic or the ER, they needed to have 2 temperature checks and 3 history and symptom checks between the front door and the clinic room, 1 in the lobby, 1 at the clinic nurses station, and 1 checked by the doctor in the room before they could see the doctor. So here staff were protected by masks, goggles, hat, double gloves, but not the full bodysuit. As many patients as possible would be managed in the clinic or the ER before, rather than be admitted to the hospital. These rules, of course, now relaxed as we're fairly sure that the number of patients who are infected in Beijing is negligible. Next slide. So in the early stages of the epidemic, PPE was limited in supply, just as you found in Scotland. In order to protect staff, then many of the non-essential workers were told not to come in. We only had staff coming in who were on duty. Meetings were held remotely, and you can see that we were careful about our PPE use. Every Friday, our chief nurse in the department allocated PPE items in advance to the next week's duty roster individuals, and these were then recovered from the central supplies on the Monday to cover staff duties for the week ahead. We never had more than we needed, but we always had enough. Next slide. So what was the admission criteria for patients? We had to keep the hospital clean. To begin with, no patient was allowed out of the province. If they were outside Beijing, then they had to quarantine for 14 days. If they'd been in contact with at-risk individuals, the same. Any fever, they weren't allowed in. If they had a CT chest evidence of pneumonitis, they weren't allowed in. And then the blood tests for both antibodies and antigens. And visitors had to have the same checks before they could come in. Next slide. So obtaining a CT scan of the chest, blood tests initially took some time, and most admissions were delayed for up to 2 days early on. But of course, some patients were urgent, and then they could be processed within an hour for most tests, but antigen testing did take longer. They were allowed in without the antigen test if all the other 5 tests were negative. But for a long time, it was only life and limb-threatening diseases that were allowed admission or to theatre without a PCR result. And even then, all of the tests had to be negative. Next slide. So all patients were put in a single room. In case a patient developed symptoms, each ward had to hold 1 bay free at the end of the ward. It was very rare for patients to actually end up as positive on our wards. And usually these patients with a fever, it would come back as COVID negative. But in theory, if they were positive, they would be transferred out to another hospital. Next slide, please. So the decision-making about transferring patients out was a leadership role, and in our hospital done by the chief of anaesthetics, who was head of the COVID infection control team. Next slide, please. So my interpretation of these policies. So for many weeks, I had to implement them. Across my desk came stamped policy after stamped policy, and I had to understand what was required at the level of lockdown that we had at that time. Next slide. So at first, I doubted the wisdom of the segregation policy. I saw that in the ER, it compromised individual patient care. Patients had delayed to their admission and surgery. They sometimes went to other hospitals. And I believe the risk of cross-infection to be overstated. But as we quite quickly got the infections under control in Beijing, and I saw the continuing problems in Europe, I became gradually more favorable towards the policies instituted in Beijing. Next slide, please. So what are the advantages of separating hospitals into clean and not clean? I've made a list of 8 advantages of keeping hospitals clean, and they're as follows. So if you've got a clean hospital, then it ceases to be an ongoing cause of disease transmission, which can then be transmit patients back to the community, either visitors or patients or staff. Secondly, a clean environment is a safe environment for patients who are at high risk of severe disease. And thirdly, it's a safe environment for urgent or emergency conditions. Next slide. So there are positive effects on the presumption of clean equipment, surfaces, theatres, CT scans, and so forth. And it limits the requirement for downtime of the equipment and increases patient throughput. Scarce PPE can be efficiently distributed, and medical staff can have confidence in workable segregation policies. Next slide. There's also a positive attitude in the wider community. They're not afraid to come into the hospital. And during ease of restrictions, it's easy to begin to increase throughput when clean hospitals are believed to be clean. Next slide, please. So the main disadvantages are that staff and service reorganization is required in hospitals across the area affected. In our city of Beijing, only 3 hospitals were designated as COVID hospitals. So in those areas, patients who didn't have the disease had to go elsewhere, which wasn't difficult. The second disadvantage is that patient treatment delay can result in individual poorer clinical outcomes, and this may reduce acceptance of the policy. And thirdly, transferring non-infected patients, which may sometimes happen with symptoms, to COVID hospitals in error could negatively impact their health. Next slide. We did have a mini outbreak in mid-June to mid-July. It resulted in 200 or 300 extra cases. And Paul, maybe you can show the video and I'll explain as it's running. It's a very short video of a mall in which a patient, a poor girl found herself she was told on mobile phone that her PCR had come back as positive and that she was therefore infected. So she sat down on the floor and cried, and people around about knew what was happening, so they made for the doors, but immediately the doors were locked. They couldn't get out of the mall because the security staff had been immediately alerted to this situation, and they had to queue up to give their details about who they were, where they lived, and they would all several hundred of these poor shoppers would have to self-quarantine for the next 14 days. So this is the community program of checks and identification, which mean that we in Beijing at the moment have, as far as we know, got no active cases. Next slide. Thank you.
Daniel, thank you so much. That was excellent. It's really fascinating to hear how a different healthcare system, a different society, I guess, address this. And your comments about clean hospitals in particular intrigued me. I always pondered that myself as to a response didn't go down that route. We know we have a lot of hospitals close to each other in Scotland, and that was that a consideration for us that, you know, looking back, we would be in a different position had we done so, and is that for a future consideration? You obviously felt you'd changed your mind and that actually was a good policy. Is that a fair summary?
Yes, to begin with, I saw the negatives, Alistair. I saw in the emergency room patients who were too scared to come into hospital. Even with fractured neck femurs, they would prefer to go home with their families and be treated at home in their beds without medical attention than to come into a hospital where they thought that they might succumb because of the unknowns about COVID in those early days. And of course, because we were keeping our hospital clean, it was difficult for patients to come in at all. It was particularly for children to have a CT scan of chest and to take time to have all the negative tests is an imposition, and it did negatively impact on the personal individual care of patients. But it was accepted. There wasn't within the wider community obvious disquiet. It was accepted that because SARS, the experience in SARS had resulted in this sort of program, which had been successful in eradicating SARS over the course of 18 months, it was also the right course at this point in time. And there was great faith placed in the doctors like Professor Zhong from who'd done his MD here with you in Scotland in the 1970s, 80s. Great faith in him and with his colleagues that they would, as they had managed to abolish SARS, also manage to abolish COVID. And to this point, it doesn't seem that they're wrong. But the caveat is we live in Beijing, and a very different society, different culturally. There is compliance with what the government says, and people know that if they do deviate from what they're told to do, they're going to be in trouble, so they don't.
Yeah, no, I think that's absolutely true. And I think perhaps maybe our testing capabilities were not there either at the start to allow that kind of segregation. I see there's a question from Hamish. Nick, do you have the question?
Yeah, it was just if the patient is admitted with life or limb threatening injuries but doesn't have their 5 or 6 negatives, what would you do with them?
We had to stick to the hospital policy, which was they had to have the whole batch of negatives before they could go to the operating theatre. So the caveat is if it was a life-threatening injury or a limb-threatening injury, a vascular injury, or a major traumatic injury that was going to put that patient's life at risk, they could go to theatre, and then they would have all the precautions that were necessary within our hospital. That was a very rare occurrence. If the patient looked like the patient looked as if they might be infected and they were life or limb threatening problems, they would be sent to a COVID hospital. If they could wait until we got all the tests together, then they would have to wait. So many patients waited for several hours to get the test necessary to let them go to theatre. And we preferred to do that in order to maintain the infection control policies that we had to really maintain.
Oh, well, thank you very much again, Dan. I'm afraid I wish we had more time to talk. It'd be fascinating to hear more about how things have been in Beijing. But let's move on now, and if I may introduce our second speaker, Professor Phil Turner. Phil is a consultant orthopaedic surgeon at Stepping Hill Hospital in Stockport, a knee specialist, and is past president of the BOA, so known to most of us. Phil's been chairing the orthopaedic committee of the BOA, and I have certainly found the work of that committee and Phil's work over the COVID period extremely valuable in trying to interpret the myriad of contradictory information that's been emerging from the 4 nations and guiding us through from a BOA perspective. And my own personal thanks to him and his committee for their work. I look forward to hearing from Phil about your own views, the BOA views of the COVID pandemic and where we may go from here. So over to you, Phil.
Okay, thanks very much. I'll have a go at sharing the screen and hope it functions. Okay, so I hope that's all functioning. So thank you very much for inviting me to contribute to this meeting, and I'm only sorry that we're not together. I well remember when I was president coming to the winter SCOT meeting and having a thoroughly enjoyable time. So I'm going to spend about 15 minutes just covering what the BOA has done, what we are doing at present, and what we still need to do, particularly to support the recovery of elective orthopaedic services. And it'll quickly become apparent that this is very much the view from England, even though we're the British Orthopaedic Association. It's just a fact of life that we are asked for feedback on the various policies and guidelines that come from NHS England, Public Health England. So we get tied in very much to sort of England-centric view of the world. So in April 2020, Simon Stevens came out with his first letter to the NHS, which even at that point was encouraging regional teams to start looking at how they could ramp up routine, non-urgent work if there was capacity. And then in August 2020, 1st of August, his phase 3 letter came out, and this is what Alistair was referring to, of gradually ramping up non-urgent activity with the intention of inpatient work getting to 90% of what we'd achieved before COVID in October. and up to 100% of outpatient activity. And I can say right now that we are nowhere close to this, and it isn't clear what the financial penalties or encouragements may be that go with this. But what was interesting is the last bit where there's encouragement to manage the problem at a systems level. So that is going bigger than just your own trust or hospital. This is trying to put it all together at what you would call an integrated care systems level. So for myself in Greater Manchester, this would be a system that covers the whole population of 3 million people. So the first thing that we did once we're past the peak of the pandemic to assist this was develop the BOA guidance, which at the moment we've taken down because there have been 2 documents that have come out which mean that we have to radically change the guidance. But it was very much guidance and not guidelines, because the evidence was constantly developing. We couldn't come up with fixed opinion on what could or should be done. There is now actually quite a marked lack of central guidelines, and this comes down to the ability of local trusts to actually interpret what comes as well. So there's no sort of necessity to actually comply with many of the guidelines that come, and perhaps I'll come back to that. And the diagram there shows the heat map of cases as they're arising at the moment in Greater Manchester. And so what you will do for the whole of Greater Manchester in terms of how confident you are that you can restart elective work is not as great as it would be if you were in the southwest. So we're still under a partial lockdown. And where it's very hot up there in Oldham, it's even more difficult, and very difficult to be able to get going with that type of work. There's also marked variation in how services are organised. So services will be organised very differently across a region, within a city, and then you've got to think about the anatomy of your own hospital and your ability to be able to actually separate out green pathways. So guidance can't be all that tight. It's really more a list of suggestions rather than actual guidance. And you still have to work with a great deal of caution. As it's very interesting to hear what Daniel was saying about the fear of hospitals. This was certainly true early on, but patients who come to clinic now, I think, do have more confidence, and very few are saying that they won't come in. Around about 3 months ago, we looked at what patients wanted on a waiting list, and about 20% decided they never wanted to come in, 20% wanted to defer, and 60% wanted to carry on. It's around about 90% now want to carry on. So it's changed a lot, the perception of the risk. We have to be careful about infection risks as well. We were originally mainly worried about patient to staff transfer and that all the PPE problems that we had. But in fact, the bigger problems now are staff to patient and staff to staff, which has been shown where there have been flare-ups within hospitals. And then the problem of patient to patient transfer when they're all put in a bay together at less than 2 meters apart. I think most places now in England have managed the priority 1A and 1B cases, but again, some centres, as Alistair was saying, there's such wide variation, they're still struggling to catch up with priority 2. So a lot of work was put in about the readiness to restart, and in May 2020, the anaesthetist came out with this very useful document about restart, which suggested establishing recovery management team that covered all the specialties and the nursing side, establishing separated what were then known as green and blue pathways, although these are a bit outdated following the most recent document, and very useful covering the things that you had to be able to do to be able to restart elective work. So you had to have enough space, you had to have enough staff, you had to have enough equipment and drugs, and you had to have the systems in place to be able to support restarting elective work. And at that time, there were really 2 key principles. The first was to separate out your 2 care pathways. So the green COVID protected pathway, which was the elective pathway, screen and test negative, isolated pre and post-op, physically separated in a separate part of the hospital, staff separated, and we come back to that later, but that is a very difficult thing to achieve in a district general hospital. But one thing that was being forced by many trusts was to lose the ring fencing for orthopaedics. So they were put in place a COVID protected pathway, but everybody wanted a piece of that COVID protected pathway, the general surgeons, vascular surgeons, and it became very difficult to ring fence it for orthopaedics. So most places really put the foot down and said, we're not going to start unless we can have ring fenced facilities. And the blue is COVID managed, self-descriptive from what you can see. And the key principle too is establishing appropriate facilities. And this was just the way it came out, but it really does look sort of winners and losers, doesn't it? So the gold, silver and bronze. So the gold facilities are those like Royal National Orthopaedic Hospital, Royal Orthopaedic Hospital, Oswestry, which were standalone sites that really had no access for COVID patients whatsoever, or no requirement to take in unselected patients, with separate facilities, robust screening and testing that you could put in place, and all the codependencies also green on the same site. Most places, I think, have managed to establish a silver level by a separated pathway that keeps the patients who are screened and tested separately. But I'd be interested to know how this has been managed in the hospitals in Scotland. So the next document we played a large part in producing was the prioritisation by pathology. And the sort of bottom line with this, when we had to produce it, NHS England really wanted to have the whole of all aspects of surgery on about 5 sides of A4. So you can see how difficult it was, and it was impossible to make it as granular as we really wanted to try and make it. And this is constantly being revised still. So we're giving it back every month to review it. And we have problems such as, no, you can't separate out spinal surgery, but pediatric surgery, pediatric orthopaedics could go on its own. So we had a lot of battles with this to try and establish some common sense. Then, of course, we had prioritization by risk, and I think most places have used the CDC originally. This has got more refined now, but by combining your prioritization by pathology with your prioritization by risk, you can come up with a matrix and decide where your patient sits. Unfortunately, we found a few units where a lot of gaming goes on, and every arthroplasty can't wait longer than 4 weeks and gets put in as category 2. And that does the hospital no good, the patient no good, and the reputation of orthopaedics no good by doing that. So where there are problems, we do advise using MDT review. So your attitude with this failing knee replacement, whether they should be admitted, would be very different if it was an 82-year-old with multiple comorbidities versus an otherwise fit 62-year-old who you may want to get on with it. So the next document that came out was the NICE rapid review, and you'll all be aware of this. And the key thing was coming out with the 2 options for maintaining green pathways for patients who are going to be admitted for elective surgery. And NICE documents, I think most of us will say, are usually great examples of clarity, but this wasn't, I think, and it really is open to a lot of interpretation. So you have option 1 of isolating for 14 days, testing at 72 hours, screening on admission with no real advice on what to do post-op, all done to avoid getting COVID pneumonia in the perioperative period. And option 2 with 14 days social distancing, or really almost quarantine, test at 72 hours, then isolate, social distance for 14 days, test at 72 hours, then only isolate following that test, and screening on admission, again with no post-op advice. And you could potentially end up with a list with 2 patients coming into the same list, one of whom has been down option 1, one of who's been down option 2. And is it reasonable to mix patients who've been down different pathways? And it's based on the patient's own risk, really. But to come back to the importance of prevalence in your community and that heat map that I showed, the figures would suggest that if you go down option 1 with that full isolation, say in Gloucester, then the chance of developing pneumonia in the post-op period due to COVID is about 1 in 30 to 1 in 40,000. If you do the same thing in Blackburn, then it's about 1 in 2,000. So your local prevalence has a massive impact on the risk that you're taking. Okay, so further guidance then came out from infection prevention and control, and we've gone probably back to where we started of red, amber and green pathways. So the one we're most interested in is the green pathway for planned and elective procedures. And again, this plays into the NICE guidance which has been sent round, but it doesn't tell you which of those two options to pick, which is the preferable one. The key points though on the low risk pathway, the green pathway, are these statements: standard theatre cleaning and time for air changes, appropriate for levels of infection prevention and control, no requirement for additional cleaning or downtime. So this is trying to get back up to speed. Airborne precautions not required for AGPs on the low risk pathway, and that's for any AGPs, including intubation, extubation. So this again is to try and speed up how things go. But of course, we've spent months instilling sort of fear into our nursing staff and in the anaesthetists, and to suddenly change and to say, no, it's actually all right, is a bit of a big ask when there may be not great confidence in that screening and testing which has gone on. So just to come to the remaining issues, first of all, you've got to look at the whole patient journey. So you've got to look at what's actually on your waiting list and what does the patient want. So NHS England now is producing some shared decision-making tools to guide the conversation with patients who are on the waiting list. And to be honest, they are almost designed to try and put patients off the way it's done. And the patient groups who've seen this are quite angry about this because they've been on a waiting list a long time. They want surgery, they need surgery, and then they're going to be faced with interviews, not necessarily with clinicians, but being guided through a decision-making tree that may end up with them saying, well, you don't really want your surgery, do you? And it's very interesting that one of the trees around this is anger management, how to calm down a patient. It's actually an official line on the pathway. So we've still got to see what's coming into the system. There are a lot of self-management resources out there now. You've really got to establish good referral pathways and good triage systems so that we can manage what's still coming in. In theatre, we've still got issues over how to establish a green team, encouraging local anaesthetic and regional blocks. Your sort of standard operating procedures have really got to be developed locally depending on your theatre layout. And you've still got to think very hard about your staff and skill mix. Throughput is still way down. Certainly on the trauma side, we're finding we're about 50%. It's still very hard to get beyond one hip fracture per list. And it seems to have become almost a fixed mentality that that is all you can do. Dual consultant operating is coming in for more complex cases. And I think that's a good idea because many are actually de-skilled if you haven't done complex surgery for many months. And certainly from my own point of view, doing my first complex multi-ligament operation for a knee after 4 months of not doing it suddenly becomes a really big challenge. And issues about training, which I'll be interested in listening to later on, Alistair, when you come to that. And also problems with company reps not really wanting to come into theatre to support you for more complex cases too. You have to plan your discharge before patients come in. Enhanced recovery to minimise inpatient stay is key. Rehabilitation will be directed rather than hands-on, so that's pretty difficult. And I've certainly got 2 total knee replacements done just before lockdown who've ended up horrendously stiff because they just went home and did nothing. And we've got to audit our outcomes, COVID surge. I'm aware of the impact study you've done as well, and then a more recent rejoin study which is coming out of Oxford to look at the arthroplasties. So what about the England waiting list? So we now have nearly 300,000 who've been waiting more than 18 weeks for elective orthopaedic procedures, 11,000 waiting more than a year. And that's on the basis of new referrals only being 50% of what they were in 2019. In June of this year, 7,433 elective patients were admitted versus 47,500 in the same period last year. So that's about 16% of what we'd achieved before. And we're worse than any other specialty. So all specialties other than orthopaedics, their activity was up to 32%. So what are the next steps for the BOA? We need to get information back about how trusts are performing. It's very difficult to get, and actually NHS England want this information from us because they can't really get it. But the throughput, just as Alistair says, is massively variable. And the most recent survey were anything from less than 40% pre-COVID throughput to 100%. But 100% is not good enough with the size of that waiting list. We'll never catch up with 100%. Training issues, which you're going to talk about later. A really big issue is the independent sector. Many hospitals have not negotiated with private hospitals for accreditation for training. This is still a major issue in England. And also how much and for how long the independent sector is going to be used, and how you manage patients who are operated on in the independent sector medically when things don't go well. And then there's a big push for whole system change as well. So in London, Tim Briggs is leading a very rapid change in how orthopaedics is provided using GIRFT and using model hospital data. I can say that this is, it needs a massive political will to do it. The most important thing is pushing our patients. They're in pain, they're being put on opioids, they're becoming addicted to fentanyl patches, they're not being well managed. We've tried to push this with the press. I had a long interview yesterday with a journalist who's going to produce something, I hope, in the Saturday Telegraph tomorrow to try and push this. But everyone is up to the shroud waving, I'm afraid. Cancer and cardiac are going to win out over us. We just got to make sure we're not left out, because our patients are suffering, there's no doubt. And I think finally, we just have to be prepared. We're making plans to press on. But the first part of that Spanish flu curve doesn't half look like what our curve is looking like at the moment. And I think this is a cause of considerable anxiety of what's going to happen as the winter progresses. So I'm normally a fairly optimistic sort of person, but I'm not quite sure how optimistic I am about how we're going to manage this as we go through the next months. Thank you very much.
Well, thank you very much indeed. That's an excellent presentation, and I think addressed a great many of the areas that have vexed us as well in Scotland, in terms of prioritisation for our patients' access and the variation which is evolving. And I see Professor Leitch has joined us just now at just exactly the right time. Thank you very much for joining us.
I think maybe I'm a little bit late. The end of that looked fascinating. I wish I'd seen more of it.
Well, the session is being recorded, so hopefully you'll be able to look back on presentations if people would like to do that. I should have said that at the beginning, which would have been helpful. So, but thank you, Phil. I think there may be one or two questions our Secretary Nick could put to you before I introduce Professor Leitch as our next speaker.
Yes, well, actually, just both from you, Alistair. If anyone does think of anything last minute, just tap it in quickly. But the first question for you, Prof. Turner, was what is the BOA's view on how best to prioritise patients to ensure that our patients get appropriate access?
Yeah, it's a big problem because you know, we battled with prioritisation within our own specialty, and when it comes to prioritisation, it comes out against other specialties, if you like, that we will struggle. But the hand that we've got, I think, is just the size of the waiting list. It is just huge. I mean, and it's almost trebled in England over the period of the pandemic. So we have to push it. We have to look at innovative and novel ways of doing this. And I think this will be a push to changing how we provide orthopaedic services, centralizing them into larger, high throughput elective units, high efficiency, that will work as 3-session days and ultimately 7 days a week. It's working harder and working smarter. We've got to do both to show that we can do what we can to catch up. We can't suddenly juggle up a whole load of fully trained orthopaedic surgeons who are going to be able to cope with this. So we've got problems. And I think, unfortunately, the trainees are going to suffer in this as well, because everything is going to be for efficiency and speed, and we've got to be absolutely sure that training doesn't get pushed out of the way to achieve that high throughput. We've got to use the opportunity that will come with this to train really well and train smarter as well.
Thanks. And the second thing, this was discussed quite a lot at our SCOT committee meeting this morning, and I'm sure you've had similar discussions, but there's obviously huge variation across both countries in terms of recovery sort of in this phase of COVID. So what are the main reasons that you've seen why some sites are simply not recovering as quickly as others?
Yeah, a part of it is down to local prevalence. So it tends to go with what people are managing to achieve goes with the actual prevalence of COVID in the community. So around where I am up in the northwest, we're sort of down in the 40%, down in the southwest and Bristol and other parts of the southeast. They're the ones that are actually up to the sort of 90, 95%, 100%. So it's the actual ability to really transfer your focus onto elective orthopaedics. There is an element of political will that comes with it as well, I think, and managerial will that you have to get on board. So you have to get on well with your management to do this. But the biggest correlate seems to be actually what's happening with the COVID in the community.
Thank you, Phil. That was
Thanks.
very
Nobody.
helpful.
Yeah, there's no other questions, Alistair. So.
Okay. If I may, for time then, I'd like to introduce our last speaker for this session, Professor Jason Leitch, who's our National Clinical Director for Healthcare Quality and Strategy in Scotland. I'm most grateful to him for joining us at an exceptionally busy time for him and many others, of course. Obviously, the title of National Clinical Director comes in the remit for NHS planning, quality improvement, and many of us have seen you, Jason, with a fairly high profile over the last several months representing NHS Scotland during the pandemic. So we're very much looking forward to hearing your views of your experience and perhaps where we go from here. And I hope you'll be able to take some questions at the end, which will be submitted to Nick as you go along. Thank you.
Great, Alistair, and thank you for having me. I'm keen to do that, actually. I'll maybe spend half of our time giving a fairly broad, you may have done some of this already, and I noticed at the end of Phil's talk some comparison to the Spanish flu. I've got that graph, actually, to make a similar point to the one Phil made, I think, but we'll come to that in a little while. Let's first of all try the tech to see if I can share my content. No, I don't want to screen record.
I can run it for you from here if you prefer.
It might be quicker. I've got I'm using a foolishly. I'm using a new iPad, so perhaps you could do it. So go to the next. Can I click, or do you have to do it for me?
I need to. Give me a shout.
No problem. So let's start with some global context, shall we? And forgive me if you're fed up with this global context, but would you believe it's 7 months ago when the WHO declared what they call a global public health emergency. And they have a category, they have a committee that decides that. So if you go to the next slide, that's been declared 6 times in the modern era, let's call it. And these are the 6 global public health emergencies. Now we could talk about any of them for an hour, but let's just choose Ebola really briefly. 2014, West African outbreak. The whole world is warned that this is now not just a West African problem, this is a global public health emergency. And governments have to pay attention to what that means. They have to do stuff. It infected globally 28,500 people. And it's hugely infectious and it's horrid and its mortality rate is high and it killed about 1/3 of it. Scotland got 1 case and that 1 case caught it in West Africa. She was treated in the Royal Free in London. She survived. Pretty much everybody knows her name. She was on the front page of the paper. Now let's compare that to the 2019 declaration of a global public health emergency. Same thing happens. Tedros comes on the TV and tells all the countries of the world to pay attention. There is a global public health emergency. And as of yesterday, 24 million people have had this virus or have at least had a positive test for this virus. We think it's probably closer to 100 million, because we don't know what's happening in sub-Saharan Africa. We don't really know what's happening in China, and the whole swathes of the country, whole swathes of the world don't have reliable test numbers. And it has killed now this week over 800,000 people. This is like nothing the modern era has ever seen. Do not underestimate its effect on every single facet of society. It is not like previous global public health emergencies in our lifetimes. Its closest comparison is Spanish flu, but it doesn't compare well with Spanish flu because the world looks so completely different. One of the reasons for the waves of Spanish flu was that we didn't travel as much as we travel now. So that may help or hinder. And we have huge resource and money into what this might do. So the next slide begins to unpick what we've done as a world. This is the grass market in Edinburgh. Many of you will know it. Many of you will have drunk in it. It's half a mile from the castle. It's one of Scotland's busiest social areas. It is cafes and restaurants during the day, pubs and drinking at night time. It's as busy as this at 4 AM as it is at 4 PM, and so it should be. It's a terrific place to be. And the next slide shows it on the 24th of March. This is the middle of the afternoon, 24 hours after lockdown. This is what we did to the world, because we didn't know what else to do. This virus was 2 months old in the Western world, 1 month old in the UK. And the best metaphor I've seen for it, we'll come to in a moment, is the hammer and the dance. This was the hammer, because it's so infectious and kills 1% of people who get it if you apply it to the whole demographic, hospitalizes 4% of those who get it, roughly. The only thing you can do while you gather time to do other stuff, next slide, is to shut down your society. That's the treatment plan. So the diagnosis is COVID-19. The treatment plan is time and societal and population change, because there's no treatment for this virus. That is on the edge of serious illness, but fundamentally there's no clinical treatment for people who get this virus. There's some supportive therapy and some steroids might help if you're seriously unwell, but your course is pretty much set when you get infected. The next slide. So as time passes, the treatment changes. And that's principally because we've learned and science has taught us how to manage this particular respiratory virus. And the smart ones amongst you will notice 3 massive outbreaks around the country. The Aberdeen city outbreak based on nighttime hospitality. Now over 400 people infected, 260 of them caught it in the indoor hospitality on the famous weekend about 6 weeks ago now, and about 150 of them caught it from those people. There are now 6 admissions in Aberdeen Royal Infirmary directly related to that outbreak, and a couple of them are seriously unwell. The Sidetail call centre, which you also saw us handling over the last little while, and then more recently, I know more about chicken farming and processing in Scotland than I ever thought I would, and that's the Cooper Angus outbreak. The only remaining chicken processing plant in Scotland kills 1 million chickens a week, and now has 160 workers, all positive. 19 different languages spoken in those 1,200 employees, spread throughout the whole of NHS Tayside, and a massively complex operation for the health protection teams, and so far very well managed and controlled. So that is the new way of treating it. That is whack-a-mole, if you like. It is dealing with outbreaks in a public health way. And the next slide draws that metaphor out a little bit. And I can't take credit for the design. I can take credit maybe for the images. But what Thomas says in an article, now a couple of months old, is that you have choices in what you do as a country. And if you do nothing, your case is sore. And you've seen that in some countries in the world, not many, almost every country has brought in some form of the hammer. And don't believe everything you hear, for instance, about Sweden not having a lockdown. It has a lockdown, it's just chosen to do it in a slightly different way from most of the mainstream countries. You can mitigate, but your cases will go out of control because your R number will be over 1. And you can reduce your curve. You can reduce your curve by shutting society and stopping transmission. And that's what we have done. And that's what most Western European countries and many others around the world have done. And now we're in a period of reopening society, business, sport, health and care, pretty much the society is becoming to me a bit like an onion. Every time I think we've found all the bits of society, I get asked a different question. So last week I was asked whether trampolining could open. I never thought when I was doing dentistry and then oral surgery that I'd be asked one day whether the trampolining clubs of Scotland could reopen in the middle of a global pandemic. The answer is they can, as long as they have the mitigations in place in case any of you wish to go to trampolining at the weekend. The next slide, please. And this is what that looks like in a slightly more technical manner. This is the infection curve in that first wave of COVID. This comes from Neil Ferguson, now slightly notorious because he broke the lockdown rules and lost his advisory job to the UK government. Very, very smart guy, and a lot of the modelling comes from his unit in Imperial College that has helped us the whole way through this. And you can see what each of these elements does. Isolating the positive cases, isolate the positive case and the household, close schools and universities, and gradually as we increase, those curves return because the virus is the same virus we had in March. It hasn't changed in any meaningful way. It is not less infectious. It is not less virulent yet. That may come, and we can have questions on those elements if you'd like. Next slide. So this is what we did with the hammer in March. We closed quite a lot in the middle of March, and then on March the 23rd, we did the final version of this, where we basically put everybody in their houses for 3 months, at least 3 months, unless you had essential reasons to leave. The Lord Advocate, who is the protector of human rights in the country, he and I have had to get to know each other a little more than I would conventionally have hoped. And he makes a very good case for everything we do has to be proportionate. So you have to have a public health argument to shut the schools. You have to have a public health argument for today's change in the law to break up house parties over 15 individuals, because we have restricted the rights of people to meet, to conduct their normal lives. This is a completely unprecedented set of laws and guidelines on the back of a global pandemic that is unique in our time. There unfortunately is no lever arch to take from the wall to tell you how to manage this. Next slide. And again, now we're here. Now we're in the facts, which is face coverings and avoid crowded play. You can't have missed it on your TV, and I apologise for interrupting your soap opera watching. And quarantine, isolation, and contact tracing. Test and protect becomes a crucial tool in the delivery of the big outbreak reductions, the ones we've just described, but other places, other small outbreaks, test and protect has done almost invisibly shut down those outbreaks, even as the schools have reopened. Next slide. So this is our aim, and I'm gonna finish in a moment or two because I want to give you the broad non-health elements of what we're trying to do here. We're trying to not only reduce death from coronavirus, of course, because unemployment is a public health problem. Addiction is a health problem and brought on often by mental illness and other elements of your lifestyle. So the next slide talks about the 4 harms that we're trying to deal with. Next slide. There we go. And everything we do in the route map out of this crisis, we do through this frame. You can actually download, it's not particularly interesting reading, but you can download the 4 harm assessment at every 3-week period. And every 3-week period has to have a balance of each of these harms. Now, Gregor Smith and Fiona McQueen and I are responsible for harms 1 and 2 and the advice in harms 1 and 2. But Carol Tannehill, who's the Chief Policy Advisor in social harm is responsible for harm number 3, and Gary Gillespie, who's Scotland's chief economist, is responsible for gathering the assessment of harm number 4. You cannot come out of a global pandemic only concerned about disease from coronavirus. You have to worry about, for this crowd, orthopaedic challenges. You have to worry about cancer, but you also have to worry about what you've done to young people by taking them out of school for 5 months. 110,000 children in Scotland have free school meals during the school holidays. 110,000 children get free school meals during the school holidays. So you cannot shut schools without harming individuals. And it's really important where we try and make decisions about what we're going to open, when we're going to open it, what's the next plan, how you're going to manage that COVID. You have to do it in the light of closing small businesses and retail shutting or whatever. And I've never liked the essential versus non-essential business. If I own a gift shop, that's pretty essential to me and those I employ and the food I put on the table in the evening. Never mind if you're already vulnerable or homeless or addicted or whatever else you are in society. Next slide. So this is what the COVID harm number 1, looks like. And I don't have decent slides yet for harms 2, 3, and 4, but I need to do that for this kind of core presentation. About 1,000 people a week die in Scotland in peacetime, in normal times. And you can see that in the middle of April, we doubled that. In the middle of April, our mortality rate in Scotland basically reached 2,000 a week for a few weeks and has been dipping ever since. We've not had many deaths, but we have still got a tail of deaths, and there are some admissions over the last few days, some of which may not manage to get out of intensive care, principally around these larger outbreaks, which is what we expected to see, sadly, and is much, much lower than that first wave of mortality. Next slide. And this is the criterion we use. So we use the 4 harms framework. And then after that, we then look at, are we managing these 6 things? And the advice we give to the First Minister is based on our ability to control these 6 elements. And we don't have time to talk about them in any detail. But briefly, are you controlling the transmission of the virus? Do you have capacity to test and trace, or test and protect in our world, and quarantine those who need to quarantine? Are you managing outbreaks in healthcare settings, prisons, care homes, highly vulnerable units like learning disability homes, where you would expect the virus to be much, much more dangerous? Do you have workplaces ready for return, be that an office block, a hospital, a school, whatever that is that you're opening? Importation of cases, and you can see us playing on the head of a pin about quarantining individuals who come back from certain parts of the world. We added Jamaica overnight, and we added, I forget who else we added. Can't remember, doesn't matter. It gets very confusing. And then number 6, which has partly been my job, about trying to engage with communities and the population around what they have to do. And that's got much more difficult. It's much easier to give a message, stay at home, stay in your house, don't go out unless you need eggs and milk, than it is to start to talk about numbers you're allowed, who's allowed to go to work, who's not allowed to go to work. Next slide. Let's miss that one out. Next one. And here we're gonna finish in a moment. This is the generic pandemic graph. So this is what the virologists tell us will happen in a pandemic, roughly. So you're inside the pandemic, we're alerting it, then you have the big response, you recover, there may be a second wave, who knows, it's difficult to know, but the next slide, which goes back to where Phil was, is the true curve of what happened with Spanish flu. Now, you shouldn't superimpose this over COVID, but it is a warning to all of us that if we don't get the route map correct and the science doesn't help us, then the second wave is much, much bigger historically than the first. The first wave was in the summer. Remember, there was no health service to speak of in 1918, so we have considerable advantage, but nor were there hugely dense populations like we have now, where the virus can spread very quickly. There was no international travel. that will not have any great status. And you can see the major deaths happened over the winter period in 1918 into 1919. Next slide. And I'm going to go from here, so I'm not sure who's clicking the slide, but I want to go from here to just the ambulance right at the end in a moment. I'm going to talk about this briefly, and then let's go to the ambulance, which is the last picture. We'll miss out everything that comes in between. This is where we're headed. We don't have time to do this slide credit, but you can have these slides. This is a driver diagram back into my old world of quality improvement. It's kind of the system on a page, or it's an attempt to have the system on a page. Now, we know we can't get rid of this virus. We cannot destroy it. Science may help us in the future, but just now we can't. So let's say we're trying to have no cases for 28 days. What would you have to do? Now, there is cost to all of this, and it may not be the correct aim to try and do it, but this is what you would have to do in order to get no COVID cases for 28 days. International borders, UK borders, you'd have to communicate with the public, you'd have to isolate and quarantine all the positive cases, you'd have to have infection prevention control, you get the idea. You'd also, of course, in the light blue at the bottom, you'd have to support society to not do the normal things. So the job retention scheme, the so-called furlough scheme, has been an attempt by the governments to support people not to spread the virus by closing down their businesses, furloughing staff. But how long can you afford to do that, both from a public health perspective and from a financial perspective? So let's go to the ambulance right at the end. You may have to click through, or you might be clever enough to get there in one. There we go. Well done. Good man. So my final comments are just a personal story of COVID. I've got a very good pal who's a paramedic. He's 41. He's fit. He exercises all the time, a lot fitter than me. He's got 2 young kids, a 7-year-old international gymnast who's a boy who's been yelling at me to get his gym open. Apparently he's quite gifted. He's happier with me this week than he has been for some time. And an older girl, an 11-year-old. He caught COVID on the 9th of April, probably in the line of duty, but we may never know. And he got proper sick. I'm not sure if you're familiar with that classification of disease, but he got proper sick. He was ill for 3 months. He has no pre-existing conditions. He is normal weight. He's in his early 40s and he is fit. And his wife got genuinely worried about him for a few days and wondered if he would make it. He did. He went back to work 2 Mondays ago. He's had to change his shift pattern because he's absolutely knackered. By his own admission, after a shift, he can barely walk up a flight of stairs. This disease is not just at the high end of mortality. It's a horrible, horrible disease to get for a percentage of the population, even those who perhaps think they're immune to it. So I don't want to depress you, but that's where I thought we would stop. So I'm happy to take any questions. If you stop sharing the screen, I'll be able to see some of you. So please feel free to go wherever you wish the conversation to go.
Jason, thank you very much indeed. I think that was an excellent presentation to remind the bigger picture, I guess, and where all the challenges lie. And I'm really struck by your phrase at one point of how we're in the middle of the pandemic, and I think that's something for us to recall. I'm sure there will be questions. Nick, I think you have some.
A couple of questions so far, yeah. I suppose just related to really your last point, this is from Mark Blythe. Is there any evidence that patients more recently affected by COVID are becoming less seriously ill than those infected earlier in March and April?
Yeah, it's a great question. There's no mainstream science globally that says the virus is changing in virulence. There is, though, definitely in Western Europe, fewer admissions and fewer deaths. So now we need to work out what that is, and we don't know yet. Lots of theories. One theory is the virus is mutating, and it may be less virulent, might be more infectious, less virulent. And some virologists think that makes sense. Remember, viruses evolve very fast, and they evolve to survive, not to kill, if that makes sense. So they like infectiousness, they don't really care about mortality. Does that, I mean, that's virology in 2 sentences. It's not particularly technical. So it may be that the virus evolves to survive better. So the more people it can get to, the more likely it's to survive. However, that's not confirmed. The virologists are hoping that's true. The more likely present scenario is, as we've opened up Europe, and every country's done roughly the same thing, indoor hospitality, some people back at work, schools back. What we've put back is younger and fitter, and they've caught the virus. Some of them have passed it on to older people and they have got sick and died. But the majority of people who have had it have had relatively mild courses of disease. And that appears to be true in Scotland. The vulnerable, those who are shielding, those who are older, now know to be much more careful and are staying out of society for longer. So my instinct is that that's what we're seeing, rather than the hope that the virus might change. But I live in constant hope that the virus might change and I can get back to the movies.
Okay, second question is from Aberdeen, consultant Aberdeen, Dave Cairns. Regarding the Aberdeen outbreak, what has the government learned about self-policing of guidelines amongst the hospitality industry?
It's a loaded and good question. I think we've learned not only in hospitality, but across every sector. And I've done oil and gas, I've done elite sport, I've done hospitality, retail, all of them. I've spoken to the chief execs, all the supermarkets. In the main, if your guidance is clear, nobody wants an outbreak in their bit of the puzzle. Whether you're a chicken factory or a ferry operator, it doesn't matter. So your guidance has to be really clear, it has to be public health based, but it has to be designed in such a way to allow that sector to at least to breathe. And to be if you're going to make it so tight that they can't open, that they can barely make any money, then don't open them. And that's a really tough balance to have. And that's why the combination of Gregor and I and the chief economist is the right thing for a country to do, because it shouldn't all be about the COVID harm. It should be about the economic harm of closing down indoor hospitality in Aberdeen for 4 weeks and people losing their jobs. So we've learned in Aberdeen that the guidance wasn't being properly followed, for sure, and that's why the local authority has inspected 180 odd high risk and low risk businesses. We're particularly worried about the very late night economy, and this, I don't need to tell this crowd what happens after 11 o'clock in these big cities. I mean, it's perfectly understandable, it's predictable. And we've tried to find ways of mitigating that with guidance, with holding the publicans and the restaurant owners responsible for that. And in the main, that has gone well. I've been out for dinner twice in 5 months in the last couple of weeks, and both occasions have been exemplary. They've had all the guidance in place, they've taken names, they've had alcohol, sanitizer everywhere, it's been great. But there are some places where that's not quite as good. And you can see us changing the regulations. You can see us today creating new emergency laws that nobody wants to do, to shut down house parties. We've made some of the regulations around indoor hospitality now the law. Again, we don't want to do that, but we felt it proportionate in the present circumstances.
Thank you. A couple more questions at the moment. So from Sarah Mitchell, who's a consultant in Fife, do you think if we have a large second wave, we should switch to clean and COVID hospitals?
It's a great question. We've thought about it, and we've done it to some extent. So the Jubilee is a clean, COVID-free institution. We've moved a lot of cancer care to the Jubilee. There's probably some Jubilee people on here, and it's done really, really well. And we've thought about let's use shorthand, clean and dirty institutions, or clean and dirty sections of institutions. I think all of that is on the table. The capacity and the design of that is really tricky. Creating a bubble of staff, creating the testing regime around it. It sounds very attractive. It's quite hard to deliver. So I would say it's still all on the table, and health boards and the remobilisation plans, which are being considered by us just now, have elements of that within it.
Okay, thanks. So from Martin Buchan in Inverclyde, my secretary, or his secretary, is inundated with calls from patients on the waiting list who think we're back to normal. Do we need a public information campaign to help our patients understand the implications of the pandemic?
Well, well, we have one of them, but you could argue it's not. It can't cover every bullet point on everything. I think adding something about what the National Health Service is at this point is good, and we tried to do that, both politicians and clinicians, around the messaging every day that we do at the podium and in interviews and other places. I've had to learn a great deal about where people get their messaging over the last 5 or 6 months, and oddly, not everybody reads The Guardian and watches Channel 4 News. It was a great shock to me that a lot of people get their information from local newspapers, for example. I thought they were all dead. Turns out they're not. And particularly in the poorer areas of our country, weekly local newspapers are crucial. So we've done a couple of wrap-around supplements for those newspapers. Also, young people get information from social media, but older demographics use different types of social media. They use different electronics. And we've tried to attack all of them. Young SCOT is our source for high school kids, for example. But the message is correct, you're right, that we do need to get advice over, and the health boards need to help us with that. So the most trusted voices are the clinical voices, not necessarily nationally. They don't trust us anymore, but they still trust local clinical voices. And if your health board is keen to get that message across, then having a voice from inside your community is one of the best ways of doing that.
Thanks. There's just 2 more questions live, so I'll probably ask for no more questions now, so we've got time to answer these. So from Petros Paskinos, Tayside, when is a vaccine expected to be made available in Scotland, and is there a timeline on when healthcare staff would be vaccinated once available?
Yeah, so there's no timeline because we don't have the vaccine. So healthcare workers will of course be a very high priority, probably straight after the vulnerable. So this there's not a good answer here, but the truth is that the optimistic vaccine scientists who are inside the Oxford vaccination group and other places, that one of the deputy CMOs in England, big respiratory expert, that with a fair wind, which is not reliable, they think we might have a short-acting vaccine this side of Christmas, but not the full-on vaccine for longer-term immunity. So they think they might be able to get us something not in 6.5 billion doses, but something that might help the high end of the vulnerable. So you could choose to give it to the over 80s, you could choose to give it in care homes, whatever. We'd have to make choices in there based on disease. And the longer term recognizable proper vaccine, spring of next year. That the mainstream scientists think that's ambitious, and they think probably the first half of next year for a vaccine that functions. The pessimistic vaccine scientists think the virus is playing games, will mutate and will never catch it. They are a small number. So most people in the labs think this coronavirus is not changing enough to not have a vaccine. The big unknown is we don't know about immunity. We simply, the first guy to get this virus in the Wuhan market has only had it for 9 months. So we don't even know if he has immunity for 12 months. We don't even really know who he is, but you get my point. The immunity, even if we could judge it now, only tells us 9 months. Now, the virologists and the immunologists can tell us what coronavirus immunity looks like. They know what normal coronavirus immunity looks like. And that's about late IgMs and T-cell T cells over a period of time, and that seems to infer some kind of immunity, perhaps for months, perhaps even for years, but we simply don't know yet. Most of the present vaccines under trial are at least 2 doses to get your T cells up to that level of immunity, and hopefully they will stay in place for some time. So if I had 100 quid to put on it, I'd say I think we will have something in the first half of 2021.
Thanks. That's really interesting. Right, final question from Jamie McLean in Perth. COVID testing seemed to be accessible until recently. Currently, there are stories of people being referred south of the border or to Northern Ireland. How is this? Is it a factor of demand, and will it persist?
It's two problems. It's demand and supply. I particularly liked all the tweets I suddenly got where everybody from Edinburgh and Glasgow was being asked to go to Belfast for their coronavirus test. It wasn't really particularly helpful. So, long story short, overwhelming demand. We went from 4,000 under 17s being tested 2 weeks ago to 17,000 under 17s being tested, 316% increase in a week. Pretty much, this is a little harsh to call it the worried well, because they have symptoms of some description, but not necessarily the triad of COVID symptoms or one of the triad of COVID symptoms. So lots of kids, some of you will have them, back at school, rhinovirus, same rhinovirus every August, whole class gets it, lots of runny noses. And a little bit of misinformation from schools saying you've got to get a COVID test before you can come back. And so we've corrected as much of that as we can. Remember, there are thousands of schools in the country, so you would expect a little bit of variation in messaging. Quite hard to get to them all. They've had to now all watch a message from Professor Leitch, which is unpleasant for them. And we've tried to get the messaging out through Parent Club, which is the one to the parents, and we're putting letters in every kid's satchel, if they still have satchels, next week. So we've corrected some of that demand problem. There is a supply issue, and we're building laboratories and supply as fast as we can. 2 supply issues. You've got to be able to take the swab, but you've got to also be able to analyze the swab. 2 separate things, both very complex. So we've now got multiple versions of getting the swab, walkthroughs, drive-throughs, NHS testing, care home testing. But the UK government still own quite a lot of the logistics of that, and that can get a little bit tricky, because if they reach a particular point of demand because the labs are going to be full, they shut down the swab providers. So they shut down the mobile testing units, and we're trying to gather a little bit more control over that. So 2 problems, very complex, and you can be absolutely certain that it has occupied most of my and the First Minister's week.
Yeah, I bet. Okay, last question from Professor Simpson in Edinburgh, which is a great question. To help the massive number of patients with severe musculoskeletal pain, given that there was insufficient capacity for elective surgery prior to COVID, are there any plans to expedite the government's plans for elective surgery centres across the whole of Scotland?
I'm not quite sure expedite, but they certainly haven't been lost. John Clonahan, who you'll know is the interim chief executive of the health service just now, and many of you will know he's been around a long time, just come back from the Republic of Ireland after being the Director General there. He and I talked about elective centres this week and what we thought was the right mechanism for accelerating and maybe post-COVID adapting a little to what we might have to do. So I still like the principle of it. I've never been entirely convinced that we should build silos of elective care in a greenfield site. I've never been entirely sure that we should separate it quite as much as some have. That's a longer conversation perhaps than this one. But yes to looking at them. They are back on the agenda in the remobilisation plans and accelerating them as much as possible. My only caveat to that is that pretty much every pound we're spending is already overdraft. So there isn't money that we've forgotten about. In fact, the budget going forward, because of COVID and everything you can see, will be tighter than anybody on this call has known in their lifetime. That doesn't mean you can't prioritise within that, and you have to make choices within that, but you just have to bear in mind that despite I and you and others wanting to prioritise it, there will be financial implications.
Thank you very much.
Yeah,
I think thank you, Nick, for chairing the questions. Jason, for that talk. That was absolutely excellent, and handling the questions. I would like to draw the session to a close. We've run over a little bit, but I was very keen to allow that discussion because there are three very valuable speakers today. Thank you to Professor Leitch, Professor Turner, and Professor Porter for your contributions, which have been fantastic. The plan now is to have a short break, perhaps 10 minutes only, to leave this platform open, and then we can go into our registrar paper sessions, which Paul Jenkins will be chairing. So I think if is there anything else, Paul, that you would like to say about the subsequent session?
Sorry, just got stuck on the technology. No, as you say, we'll reconvene in 10 minutes. And if we can have the first registrar up, Nathan Ung, to be ready. And the way we'll run it, we'll, if all the registrars are in the session as attendees, I'll promote you to a panelist for your talk, and then I'll demote you again afterwards. So, and just the usual 5 minutes for your talk, 2 minutes questions.
I should just say that obviously our presenters are most welcome to stay, but we do understand that there's plenty on everybody's plate. So thank you again to the three of you for your contributions. These were recorded, so your point, Jason, about picking up the previous presentations, they're there and we'll make them available to you.
Great, thanks for having me.
Well, okay.
Thank you.
To say that the high standard that we normally see in applications continued through, even with it being a sort of virtual SCOT meeting. So thanks very much for everybody who's submitted their research, and you know, from the looks of it, it's a lot of high quality work. So it's a great session coming up. I'm going to invite Nathan Ung to come and, well, we've already promoted him to panelist now. So he is going to talk about adolescent midshaft clavicle fracture displacement and prediction of non-union or poor functional outcome at long-term follow-up. Just before you start, Nathan, I think this is being marked by markers from the 4 regions, and the usual sort of prizes of first, second, and third will be allocated. There's also a prize for the posters, which are shown on the website as well. If people have questions, please type them as we go through, and Nick is going to keep an eye on them too, and we'll put them to you at the end. I'll give you a little tap at 4 minutes, just a 1 minute warning, because we've got to keep to time.
Thank you.
Great. Do you want to crack on then?
Yep. Okay, thank you. Thank you, Paul. So my name is Nathan. I'm one of the doctors working in Edinburgh at the moment. And today I'm here to talk to everyone just about adolescent midshaft clavicle fractures. So this is, there's no disclosures to be made for this study. And these are the various contributions by the authors involved. So just to give everyone a background, there has been an increasing trend towards adolescent midshaft fixation in the America. And almost 1/3 of midshaft fractures in the US currently undergo midshaft fixation. So we have to wonder why this is so, because there's currently a lack of high quality evidence in supporting this trend. The risk of non-union and functional limitations also remain really poorly understood. Therefore, with this project, we aim to determine the reintervention and complication rates, as well as to define the long-term outcomes following displaced adolescent midshaft fractures. This was a 10-year retrospective review. So between the years 2009 to 2019, we looked at all patients aged 13 to 17 presenting to our local region, and we followed up all of them to union. We then identified the displaced midshaft fractures as well as the angulated fractures greater than 30 degrees, and we obtained their functional outcomes in terms of quick dash as well as EQ5D. The mean follow-up was 6.5 years. So just to highlight to you all about which ones we focused on, these were the angulated midshaft fractures, and these are the ones with a fully displaced midshaft fracture. So over the 10-year period, we had 677 adolescent midshaft fractures presenting to us. This made an incidence of about 8 per 100,000 per year. And looking at the graph of the variation of the types of fractures, we can see that it's relatively static through the years as well. So not too much of a change over the 10-year period. We excluded 21 cases because 2 were deceased and 19 were not local to treatment region, so we could not adequately follow up these patients. These were all the adolescent midshaft, all the adolescent fractures presenting to us over the 10 years. And I really wanted to highlight that 90% of these were midshaft. And looking at the last 2 rows, we can see that the non-union and refracture rate was extremely low in this type of injury. Now let's talk about the angulated fractures, so the 2A2 fractures. We had 241 of these. All of them were managed non-operatively. We followed up with them and we found that there was only a 2.9% refracture rate. So it's a really low number. And interestingly, we found that the severity of the angulation was not predictive of the risk of refracture. So a patient with a more angulated fracture did not translate into a higher risk of refracture in the future. We followed up on the severely angulated fractures, and we found that we had excellent outcomes in terms of the quick dash. Quick dash was 0, EQ5D was 1, and there was great satisfaction of 95%. So looking at some x-rays, we can see that a really angulated fracture has great remodeling potential in this age group. And we can see how it healed really nicely, really illustrating the remodeling potential of the clavicle in this age group. Now let's talk about the mid-shaft displaced fractures, which are the type 2B fractures. So we had 263 of these, and 7% underwent acute fixation. 3 was because of skin compromise, 15 was because of, after discussion with the patient, they opted for it. Out of all our non-operatively managed mid-shaft displaced fractures, we had 1 non-union. It was a simple displaced mid-shaft fracture in a 15-year-old with no medical comorbidities. So the non-union rate was 0.4%, and that was really quite a low number. So it's an exceedingly rare complication. Following up on the functional outcomes, 70% completed follow-up, and we found that the reintervention rate was also really low. Only 1 osseous prominence removal was done. Quick dash was once again excellent. EQ5D was 1. There was a 95% satisfaction, and the return to spot rate was 94%. So overall, the type of injury, whether it's a displaced fracture or an angulated fracture, did not really negatively impact outcomes. So we wanted to compare the operative managed fractures against the non-operatively managed ones. We matched them for age, fracture displacement, and comminution. And we saw that, in fact, there was no differences in functional outcome or satisfaction. This is a table to illustrate that. So we compared our 15 acute fixed ones against the 77 non-operatively managed ones. And we can see that the quick dash and the EQ5D were excellent, and there was no difference in satisfaction in terms of cosmesis or in terms of shoulder function as well. So all in all, this is the largest study of our knowledge about adolescent clavicle fractures. Non-union and other reintervention or complications are really rare in this age group. And non-operative management results in excellent functional outcomes at long-term follow-up, regardless of displacement, severity of angulation, and other factors such as these. So in fact, these patients should really strongly be recommended for non-operative management. Thank you.
Thanks very much. And if I can just remind all the presenters, just to, if you mention what your contribution has been to the talk, just it's known as the Jones question.
Right. So for this talk, I was part of the collection of the data as well as the writing of the manuscript, and I've also edited the manuscript with regards to this paper.
Okay. Nick, are there any questions from the floor?
Couple of questions. First, Samantha Downey's asked, what is your follow-up for the PROMs in your patients? She's asking, it's not clear whether you contacted the patients to assess function satisfaction or if these were documented just at a clinical follow-up. So right. What's your follow-up?
You're talking about the follow-up rate, am I right?
I think, well, rate and just how is it routine, or is this with these followed up for research?
So we retrospectively reviewed the patients and identified the patients with the more severe injuries, so a full displacement, as well as a very severe angulation. And we contacted all of these patients, and we obtained a follow-up rate of about 70% over a 7-year period, 7-year follow-up.
Okay. Professor Simpson has asked you, was the remodeling of the malunions related to age, gender, or maturity?
So we did not look at remodeling per se, but we looked at the long-term outcomes as well as the long-term complication rate and reintervention rate. And we did not find any correlation with age or gender. And comorbidities wise, they were all really, they were not comorbid at all. You know, the smoking rate was also really low. So we did not find any correlation. So the general message would be that these patients do really well.
Okay, I think we'll need to stop there. Thanks very much. Can I just ask if people can submit their questions via the question and answer function rather than the actual sort of chat function? It's easier for us to keep track in the one place rather than two different ones. But thanks very much. So I will now demote you, and Andrew Hall is up next talking about the Impact SCOT report on COVID-19 and hip fracture. So I don't know, Andrew, do you want to start getting your screen sharing ready?
Absolutely, yep. I'll just screen share here. Okay. Do you think we're ready to go?
Yep.
Fine. So my name is Andrew Hall. I'll be presenting one of our recent impact project outputs, which is the Impact SCOT report on COVID-19 in hip fracture. I don't have any disclosures, and my contribution was to study design, center recruitment, data interpretation, and write-up. And I acknowledge the significant support of my co-authors, and in particular the incredible collaborative effort from each of the participating centers. Impact is a collaborative research venture supported by SORTIT, the Scottish Hip Fracture Audit, and of course by SCOT. It's a suite of international multi-center research projects, which is intended to supplement our emergency clinical research response. It includes our hip fracture audits, our research studies, focusing particularly on elective orthopedics, our global services survey, which assesses disruption to T&O hospital services, as well as our nascent Delphi study. This presentation sits right at the beginning of our hip fracture audit. The aims of the study were to assess the influence of COVID-19 on mortality in hip fracture, identify clinical predictors of COVID-19 status, and assess whether social lockdown affected the hip fracture incidence and epidemiology. We conducted a multi-center research study, a retrospective study, of all patients presented to hip fracture to 6 Scottish hospitals. It was over a 6-week period, March and April, and it was 3 weeks pre and 3 weeks post commencing lockdown. We included patients based on the Scottish Hip Fracture Audit inclusion criteria. We created a bespoke data collection tool with data validated cells to ensure that we had achieved the highest possible levels of data completion, as well as control of inter and intra-observer reliability. We collected data pertaining to patient factors, comorbidities, frailty, and COVID status, and that's both clinical and laboratory confirmed diagnoses of COVID, admission blood results, surgical factors, and outcome measures, including length of stay, discharge destination, and death. In this report, which is our earliest hip fracture study, we identified 317 hip fracture patients. 8.5% of patients were COVID positive during their admission. Only the minority of these COVID positive patients, a quarter of them, demonstrated symptoms of COVID on admission. Patients with COVID-19 had a 30-day survival of 64.5 compared to 91.5% for non-COVID patients, which is a 4 times increased risk of mortality. This was independent when adjusting for confounders. This is demonstrated by the Kaplan-Meier survival curve here, which shows the COVID positive patients in black and the COVID negative patients in gray. This second Kaplan-Meier curve The black line represents patients who were COVID positive on admission, the grey line, which is COVID negative patients, and the dotted line, which has been added, is patients who became COVID positive at a later point in their admission. As you can see, there's a lag before the mortality rate increases and follows a similar trajectory to the patients who are positive on admission. In subsequent studies, we see that that actually increases, the rate of mortality increases at a quicker rate than the patients who are positive on admission. A short word on platelets. We recognize the role of a consumptive picture of thrombocytopenia, which is described elsewhere in the literature, and found that platelet count on admission of less than 217 was 63% sensitive and specific for COVID-19 diagnosis at some point during the stay. We identified no significant differences in hip fracture epidemiology pre and post commencing lockdown. So the key messages I'd like you to take home from this, which is the first impact SCOT report, are as follows. COVID positive patients had a 4 times greater 30-day mortality. Most patients lacked symptoms on admission, which was, that has of course implications for risk modification and patient pathways. There may be a role for clinical markers in a predictive model. More work on that is required. Crucially, this study serves as proof of concept. We've responded to the need for high quality, rapid clinical audit for crisis management facilitation. It identified key research questions to investigate, particularly the role of nosocomial spread and strategies to mitigate risk. And most importantly at all, it has established our impact hip fracture audit infrastructure, which has facilitated nationwide and international multi-center prospective cohort studies. This map demonstrates that we've now received prospectively collected hip fracture data from over 100 centers across 6 continents and 15 countries. Thank you very much.
Thanks very much, Andrew. I'm just seeing if there's any questions through, Nick.
There's a question. There is one from Jennifer Cherry asking, was there consistency between sites in blanket testing versus testing of only high risk or symptomatic groups?
We know from our impact services survey that there was significant variation between sites. At the time of our study period for 6 weeks, this was actually relatively consistent, and variation began to be introduced as people adopted different strategies throughout the month of April and May. So during this 6-week period, it was relatively well controlled. Patients were tested if they were symptomatic or if they were from residential care settings or other hospital settings in which there was a risk or a significantly perceived risk at the time of COVID infection.
Can I ask, Andrew, what was your contribution to this research?
So my contribution was study design as well as recruiting the different centres, data collecting locally and coordinating the data collection in different centres. I had a lot of input from Nick Clement on the stats, and then write-up as well, of course.
Okay.
Time. Is there time for one more?
One more, yep.
Better humour, Hamish. Prof Simpson is asking Andrew, given the suggestion that COVID may be getting less virulent, and Prof Leitch has replied just before tea about the lower mortality just being due to the younger people getting it, could your data help answer that question?
I think it can do. This study that I've presented today is of course only our initial study. It's a 6-week snapshot. Our other impact nationwide, Scotland, UK and global, is a 3-month snapshot. And we've now managed to get these impact questions embedded, thankfully, within the Public Health Scotland's Scottish hip fracture audit, which will be able to give us information pertaining to patient outcomes from the age of 50 onwards, and we'll be hopefully getting some longer term follow-up as well. So mortality rate at 30 days, 60 days, 120 and at a year. So I certainly would hope so.
Good.
Thanks very much. So, Patrick, do you want to get your presentation ready to go? Just a wee note, if you try and get it set up in the slideshow, I think, Andrew, we saw your notes. Luckily, there was nothing naughty written.
Right. Hello, good afternoon, everyone. Yeah, I think I'm ready to go. Yeah, can you guys see my screen?
Not yet. Have you gone to share screen?
Share screen. Oh yeah, sorry. Can you guys see it now?
Perfect, that's great.
Hi, so good afternoon, everyone. My name is Patrick Chan. I'm one of the junior house officers in working in Oxford at the moment. And this is just a study that I did when I was a medical student in Edinburgh. So it's a matched case control study about fixing low energy disc injuries. This is to compare two different techniques. One of them is a minimally invasive technique. It's a percutaneous reduction, internal fixation. And we compared it with the traditional standard ORIF technique in treating these patients. So first of all, there was no disclosure of funding or conflicts of interests. So just to give some background, so the percutaneous technique is a less invasive method of stabilizing low energy disc injuries. It was first described in 2002, and there has been no published literature comparing the percutaneous technique with the open technique directly so far. And basically, the percutaneous technique, so the upper left photo shows a reduction clamp in place. So the patient positioning is supine. There's a radiolucent triangle being placed below the knee to relax the gastrocnemius muscle. I'll make a step incision over the lateral base of the second metatarsal and avoid a branch of a superficial peroneal nerve by a nick and spread method. We then dissect down to the deep fascia of the foot. We then open and retract the EHB tendons medially and protecting the neurovascular bundle beneath it. And the photo on the right shows the definitive fixation with a 4mm partially threaded cannulated screw. And the three photos below basically are intraoperative images of this technique. The middle one is the AP radiograph, and the right one is a lateral radiograph. So it's important to note that in our paper, we adapted a slightly different screw trajectory comparing to the original technique described. So we aimed from, so the screw started from the second metatarsal to the medial cuneiform instead of the opposite direction. And I think there are three advantages in doing this. So first of all, there's an easier insertion of the guide wire and the screw from a relatively smaller target, so from the base of the second metatarsal to the larger target, which is the medial cuneiform. And by drilling an insertion of a screw that's not blocked by the third metatarsal, and in a direction that it directly reduces the dorsolateral displacement of the second metatarsal. And the third advantage that this has is, so it's got a longer thread length purchase in the medial cuneiform as well. So the primary aim of our study is to determine the patient-reported outcomes of the percutaneous technique. And the secondary aim is to compare the patient-reported outcomes with the group of open reduction patients. So between 2012 to 2018, there were 94 patients presented at Edinburgh with Lisfranc injuries. There were 16 patients which are selected for the percutaneous technique. So the inclusion criteria for the percutaneous technique is that all of them have a myosin B2 injury only. So that involves a definite displacement between the first and second metatarsal base, more than 2 millimeters, and there's no lateral ray displacement. There has been no previous injuries to the foot, and everyone has more than 1 year follow-up. We then matched from the same database according to the sex, mechanism of the injury, and the myosin types of the open reduction patients. Blind matching was done before PROMs were collected. We used two sets of patient-reported outcome measures. It's the AOFAS midfoot score and the MOX-FQ. In terms of demographics, as you can see, so the percutaneous group and the control group shows no significant difference in their demographics. And all of them have a low energy mechanism of injury. And the results of the percutaneous technique
that's 1 minute to go.
Yeah, so none of them required conversion to open, and there was no reported complications. So the main result from our paper is highlighted here. So the percutaneous technique has got a better AOFAS score, and the MOX-FQ is universally scored. So from the MOX-FQ score as well, the percutaneous technique is better. So to conclude, the percutaneous technique is a technically simple, less invasive method of fixing disc frank injuries, and there was a low rate of complications and better midterm clinical outcomes. So in this paper, I was involved in literature research, study design, construct the database, and collected the outcomes. Thanks very much. I'm happy to answer any questions.
Thanks very much there. Are there any questions from the floor?
There are no questions.
I've got a question.
Yeah.
So the normal teaching on this has been sort of 3 screws minimum for the sort of Lisfranc frank injury. Is there any sort of biomechanical sort of backing to just this single screw construct?
Sure. So basically, from the same incision, if you want to put in more screws, we can put in more screws if that's needed. But all of the patients that we did for the percutaneous, using the percutaneous technique, all had a low energy of injury. So they only had displacement at the second TMTJ. Therefore, 1 screw is sufficient in these cases.
Thanks.
Question from Sam Molyneux in Edinburgh. Do you think the percutaneous cases were simpler and easier than the open reduction cases, i.e. was there a selection bias in this study?
So there could be a certain degree of selection bias in the study, but we've tried to minimize it by matching it to the controlled group, and all 32 patients have low energy injuries. And for the second part of the question, so the majority of these operations were actually done by the orthopedic trainees. About 80% were done by the trainees under consultant supervision. So it's relatively easy method to train and teach.
Okay, Tom Carter, any difference in the post-operative management between the 2 groups, i.e. weight bearing, post-op mobilization?
So they will be, so post-operatively, they should be in weight bearing for 2 weeks, and they can start a weight bearer afterwards. It's the same in both PRIV technique and the open technique.
And just finally from Namdi in Ayrshire, he's an ankle surgeon, were the screws routinely removed, and were there any complications related to screw removal?
So the screws are not routinely removed in Edinburgh, only if the patients are symptomatic. Then we think of screw removals, and there was no difference in the 2 groups. It was about 56% in the open group and about 40% in the percutaneous group.
That's great. Thanks very much.
Thank you very much.
So next up is Jamie Nicholson, and I'm glad to see that somebody has finally turned up dressed for the occasion. You know, this virtual stuff promotes loveliness amongst us all. But Jamie's going to talk about non-operative management of displaced olecranon fractures in the elderly, results in a sesamoid-like function. So yeah, you've got your slides up there.
Jenkins.
That's great.
Hope that's a screen working okay there. Well, good afternoon. My name is Jamie Nicholson, one of the trainees of Edinburgh. My presentation's looking at the use of ultrasound to evaluate elbow movement following non-operative management in the elderly. No disclosures for myself or any of my co-authors. The idea of the study design and scan technique was my idea, along with supervision from some of my senior colleagues. So we use AO principles to manage elderly olecranon fractures. We know that there's a high rate of complications with a loss of reduction occurring in up to 1/3 of cases and a high rate of infections. We now have pretty good evidence to support non-operative management in these fractures in the elderly and low demand patients. And it's probably worth just highlighting by stable injury, we mean ones with maintenance of the radial capitellar line and no subluxation of the ulnar humeral joint, like this picture on the right here. That's not applicable to this literature. Despite a non-union occurring in the vast majority of these patients, it's not entirely clear how a functional arc of elbow movement can be restored. And although for the majority, they have a push-off technique and able to get out of a chair or a bed, it's not entirely clear how that can happen. It's presumed it's a fibrous non-union, but no one really knows for sure. So the aim of our study was essentially to look at elbow joint and olecranon fracture movement with the use of ultrasound. We thought this might help to explain how the elbow and tricep can function, and we hypothesized this might be because of a sesamoid type function. And it's unclear if a proportion of these patients have a degree of instability which persists in their recovery. So our methods were, we looked at 5 consecutive patients over a 6-month period who presented to our clinics with stable type fracture patterns. They were seen at the 2-week mark and recruited. They had a sling for comfort and were encouraged to mobilize as able. And then they had a radiograph at the 2-week clinic to ensure there was no joint subluxation. They had a 6-week ultrasound scan and final 6-month functional outcome scans. So the 3D ultrasound is a research scanner we have at Edinburgh. We've been using this to look at callus formation in a different project. Essentially, when you take your ultrasound, it captures these with infrared and plots these ultrasound scans into a 3D matrix. And you can then build up a reasonably crude 3D picture, but the benefit of this, it allows you to orientate these 2D scans in order to judge where you want to make your measurements from. So for us, it meant we could orientate our ultrasound images and get the middle of the ulnar humeral joint around the middle of the trochlear in order to make reliable judgments. So we came up with 2 measurement techniques. One was the fracture gap, so the distance between the tip of the olecranon fragment in blue here to the dorsal ulnar cortex of the ulna, and the other was for joint subluxation, where we use the edge of the trochlear and again that ulnar dorsal cortex of the ulna. These 2 measurements were looked at in deep flexion, mid flexion and extension for the patient during active movement. 3 repeats were taken, and myself and another colleague did the scans and did our own intraclass correlation to look at the repeatability of these methods. With regards to results, all patients had a fall from standing height. The mean age was 79, majority were female. By 6 weeks, they were doing pretty well. Most had almost got a functional arc of movement, and all of which achieved this by the 12-week mark. With regards to their 6-month outcome, they had no evidence of union, but all had pretty good functional outcomes with a DASH score of 7 and Oxford elbow score of 44, and all were able to push out of a chair or a bath, and the majority were satisfied with their outcome. So the main take-home message was that essentially with the ultrasound, we couldn't pick up any evidence of instability. The fracture gap and the joint subluxation didn't show much difference between the different increments of flexion. And on this graph here, what you can see is the different increments of flexion, and on the y-axis, the displacement in millimeters. And for the mean of each patient, you can see the fracture gap and the joint subluxation remains pretty static. So no evidence of dynamic movement during flexion. If you look at the different patients respectively, as you'd expect, there's a different degree of the fracture gap between patients, but importantly, this remains pretty static for each patient during active flexion and extension of the elbow.
That's the 1-minute check.
Thank you. And the intraclass correlation between myself and the other co-author was pretty good. So there are fairly easy methods to look at with moderate to excellent agreement for the different measurement techniques. So in conclusion, this small study suggests that ultrasound would suggest that the olecranon fragment functions as a sesamoid type bone within the tricep sleeve. This may explain how a return of function can be expected with non-operative management in stable fracture patterns, and is potentially a helpful way to explain this to patients when these fractures are going to be managed non-operatively. In dissatisfied patients who have a particularly poor outcome or complain of a lot of pain in the early post-injury phase, it could be a potentially useful screening method to look for evidence of instability going forward. Thanks very much.
Thanks very much, Jamie. Whilst the sort of questions come in, do you envisage any sort of clinical utility in being able to assess which ones of these might be sort of doing okay for conservative management or not?
Absolutely, it's an interesting concept, isn't it? Roughly around 1 in 10 patients do have a degree of dissatisfaction following non-operative management. It may well be down to just simply patient selection of potentially more active patients, and actually the reintervention rate in the literature is extremely small, in the sense that most patients do cope okay with non-operative management. There may be some patients who do have a degree of instability, whether that's not picked up on the X-ray, but potentially this is an easy screening technique to ask a radiologist to do to look for excessive movement of the fragment during the arc of flexion. And we found in our small kind of proof of concept cohort that it should be static even by 6 weeks which might explain the early recovery.
Nick?
A quick one from Manish Agrawal and Lanarkshire. What was your definition of elderly? You might have said that.
So, I mean, I guess that's an ongoing debate. I mean, Mr. Duckworth's RCT used over 75. There's been previous retrospective studies which go down to even 40 in low demand patients for using non-operative management. For us, in Edinburgh, probably around 70 is the cutoff, and that's what we used for this study. But patients younger than that who are very low demand or have multiple comorbidities with a stable fracture pattern, I think it's a very reasonable treatment to use non-operative with the informing the patient of that treatment option.
And I think this is the final question from Kapil Kumar in Aberdeen. Did you notice any intact triceps fibers on ultrasound in the widely displaced fractures?
It's a great question. So I guess your tricep has a very wide attachment. We looked for evidence of bridging callus, which we didn't see in any patient on the ultrasound, but it really just looked like fibrous tissue rather than muscle fibers on the 6-week scans.
And finally, I don't know, did you answer the Jones question? What was your contribution?
That's right. So my contribution was the idea for the project. I've been doing a little bit of work on ultrasound as part of a thesis for a different project. So they came up with the ultrasound scanning technique, and myself and a colleague performed the scans, and then wrote the manuscript with supervision from the senior authors involved.
Great. Thanks very much. We will return you to the audience. And next up is Murtada Jalal talking about assessment of the quality of bone repair after autologous fat-derived mesenchymal stem cells injection into a clinically relevant model of atrophic non-union.
Thanks, Paul. Hi, everyone. Thanks for having me today. My name is Murtada Jalal. I am an orthopedic trainee in Scotland and a PhD student at the University of Edinburgh. My PhD is under supervision of Professor Hamish Simpson at the Royal Infirmary of Edinburgh and Professor Bruno Piot at the Scottish Centre for Regenerative Medicine and Dr. Robert Wallace at the University of Edinburgh. I'm going to talk about my topic today is the assessment of the quality of bone repair after autologous fat-derived mesenchymal stem cells injection in a clinically relevant model of atrophic non-union. So first of all, no disclosure about this presentation. And I will move on background. So atrophic non-union is a devastating fracture complication. The role of mesenchymal stem cells in enhancing a healing process has been examined with allogenic and xenogenic cells in transplantation models. However, certain factors might limit the use of allogenic cells in clinical practice, and it is expected that there are some issues related to disease transmission, ethical issues, and patient acceptance. On the other side, adipose tissue represents an abundant source for autologous cells, and the objectives of this study is to establish and evaluate a preclinical model of autologous cell transplantation and using adipose-derived stem cells to treat impaired fracture healing. So a methodology, we used 5 adult male Western rats underwent a previously published surgical procedure known to result in non-union if no treatment is given. This consisted of a mid-shaft tibial osteotomy with peri and endoosseal stripping stabilized by intramedullary nail fixation with a 1 millimeter gap maintained by a spacer. So here is a picture of, here is an X-ray of our model. So we use mid-shaft tibial fracture fixed by IM nail, which is a hypodermic needle. And we use this spacer to keep a non-critical 1 millimeter gap. And this was found to be sufficient to induce non-union if no treatment is given. So during the same operation, ipsilateral inguinal subcutaneous fat was harvested and processed for cell isolation. So we used an midpoint the inguinal midpoint, and then we pulled the skin down to harvest cells distally and then medially to release it from the medial side and then laterally, and that was a mini invasive procedure. So the Z-track approach that we used was associated with less wound complications and high survival rate after fat harvesting, because at the first time we used direct incision, but we have had problems with dead space formation and wound complications due to harvesting fats, and the survival rate at that time was only 2 out of 5. But with the Z-track technique, the survival rate was higher up. So we have 3 out of 3 survived after fat harvesting. So once we have done this, we so the results at the end of the experiment, all TPDs injected with autologous fat MSCs developed union, and the amount of callus was noticeably large after autologous cell injection. Here is, these were also compared with a control group injected with PBS and with allogenic and xenogenic cell transplantation groups. And the distal callus index was higher in the autologous stem cells injected and was significant compared with all these groups. Moving on to the callus radio opacity and comparison in the RAST scores, both of them were significantly higher. And we can see here on the callus.
That's a minute ago.
Okay, thanks. And both of them were significantly higher in the autologous group. And moving on to the histology, the amount of bone formation after autologous cell transplantation was also higher. And this is a specimen of histology sections stained by different histological stains. And we also tracked cells, and we found that the cells after injection were engrafted into the bone niche. So in conclusion, we report a novel method for autologous MSC transplantation to stimulate fracture.
Murtad, I think we're having difficulties. I don't know if it's at your end or just in general with Zoom. I think we'll conclude it there for time. Are you still with us for questions? Nick, or is it me, or are you there?
Oh no, I'm.
Oh no,
I think
you're there.
everyone else is here. He's just frozen on my screen. There is a question, but I don't suppose he can answer it right now. Maybe we could come back to his questions later if he's.
Yeah. Okay, we'll leave it on the board there. I will just get up our next person, who is Elliot Martinson then. Oh, it's a pity everything's been running not too bad up till now, but oh, excellent. Right, we've got a presentation. So this is Elliot Martinson with preoperative opioid analgesia, has no evident benefit and is associated with a worse outcome following arthroplasty. Hi, are you ready to go?
Okay, so I'm Elliot Martinson and I'm one of the final year medical students at Edinburgh University at the moment. And I'm just going to present my research where I evaluated the effects of preoperative opiate use on hip and knee arthroplasters and outcome measures. So there's no disclosures relevant to this paper. And in terms of contributions, I contributed with project design, data collation, statistical analysis, and write-up, and was helped along with Deborah MacDonald, Mr. Clement, and Professor Howie. So just a bit of background. So significant numbers of people are consulting the NHS regarding osteoarthritis, with current guidelines guiding escalating conservative pharmacological and surgical management. However, there are several studies which question the use of opiates for chronic osteoarthritic pain in terms of reduced efficacy, side effects and complications. And this is especially relevant in the context of the opioid epidemic, which is seen in the United States of America. So the null hypothesis that I was questioning here was that the use of strong opiates alleviates preoperative osteoarthritic pain without any deleterious consequences on joint replacement. So the study was a prospective study assessing 729 and 758 patients undergoing primary hip and knee arthroplasty for osteoarthritis between 2017 and 2018 at the Royal Infirmary of Edinburgh. Data was collected via pre- and post-operative questionnaires, with analysis being undergone via uni and multivariate analysis. So first I looked at preoperative results. So here, just to highlight, so for both hip and knee arthroplasties, opiate users experienced preoperative quality of life scores as measured via the EQ5D, which was significantly worse. Preoperatively, also, opiate users experienced statistically worse or not improved pain scores. And then moving on to post-operative results, so once again highlighting that following arthroplasty, so post-operatively, the opiate users continued to have statistically worse quality of life, joint-specific scores as measured by the Oxford Joint Scores, and pain scoring. Additionally, post-arthroplasty, so opiate users and opiate-naive patients experienced equal improvement following their arthroplasty and were equally satisfied. However, opiate users did continue to have the worst overall outcome. So in summary, opiates do not alleviate chronic preoperative osteoarthritic pain and create morbidity. They result in worse post-operative quality of life and joint-specific scoring, but both groups do improve and are satisfied post-arthroplasty. Limitations were that the data was collected via patient-reported questionnaires, so the medication information might not reflect compliance and use of repeat prescriptions within the community. Additionally, no post-operative medication data was collected. So conclusion, so reflecting back upon the null hypothesis. So we can conclude that opiate use is deleterious to patients, reducing pre- and post-operative quality of life and joint-specific scores. It provides no evident preoperative osteoarthritic pain relief and reduces the eventual benefit of arthroplasty. However, interestingly, opiate use does not reduce satisfaction or response to arthroplasty. And importantly, clinical relevance of this going forward. So currently, NICE chronic pain guidelines are being reviewed with expected publication next year. And here they state that to not offer any opiates via any route to patients aged over 16. Similarly, the SIGN chronic pain guidelines were updated last year, and these highlight the importance of shorter waiting times from referral to specialist consultation. This is especially relevant during the coronavirus pandemic at the moment, with patients waiting longer and therefore remaining on opiates longer than expected, or more patients being potentially started upon opiates during this waiting time. And the 2018 SPACE random controlled trial compared opiate use and paracetamol use, and also concluded that there was no benefit of using opiates for pain at 1 year, with twice the prevalence of adverse effects. So, thank you.
Thanks very much, and well done coming and presenting to this group as a medical student. That's a really fantastic achievement for you, and a nice research study. Did you have any sort of thoughts going through this in terms of, you know, how much we can take away from this about what of this is association and what of this is sort of causation? You know, in terms of, you know, it's a you know, very interesting, useful observation, but is there a causative link?
So I think that opiate use is very sort of multifaceted in terms of why people use it and the effects. So sort of when I was looking at my patient demographics, there were a few, so patients on opiates were younger and high BMIs, but these, because of the large data sets and the very small differences, we didn't say that was clinically significant. However, when we looked at comorbidities, there was some quite significant comorbidities in terms of sort of back pains and pain from other joints. So I think that the actual opiate use and the osteoarthritis and the fact that many of these patients are highly comorbid and have many different effects, I think it is obviously more complex than just a simple, they use opiates so they have a worse outcome. But I think there are some sort of quite significant points to be brought from this.
And no other questions coming in the chat, I don't see, Nick.
No, no more. No.
There we go. Well, thanks very much, Elliot. That was great. And next up, we've got Matthew Gillespie talking about the extent of glenohumeral bone loss not influencing the outcome from a Latarjet.
Thank you very much. So my name is Matthew Gillespie. I'm one of the ST3s in South East Scotland rotation. Today I'm going to speak about our research on the influence of glenohumeral bone loss on the outcome of the Latarjet procedure. First up, disclosures. The senior author, Mike Robinson, has a disclosure as a paid consultant by Acumed. My contribution was in study conception, data collection, and data analysis. The Latarjet procedure is proven to be successful in the treatment of recurrent anterior glenohumeral instability, particularly in the setting of failed soft tissue stabilization or associated bone defects. There is, however, a significant minority of patients who complain of ongoing subjective instability following the Latarjet procedure. Currently, there is a positive evidence as to whether the preoperative pattern of bone loss influences outcome and the risk of ongoing instability. The glenoid tract concept was developed by Yamamoto et al. In 2007 to clarify what size of Hill-Sachs lesion needs to be treated. Using cadaveric modeling, they demonstrated that the contact area between the humeral head and the glenoid through the full range of movement of the shoulder included 84% of the glenoid width. This is referred to as a glenoid tract. If the Hill-Sachs interval, which is the distance between the medial-most aspect of the Hill-Sachs lesion and the medial-most aspect of the rotator cuff footprint, is greater than the available glenoid tract, the lesion is said to be off track and is likely to engage. This concept has been refined since, using live shoulders, and a value of 83% of the normal glenoid width is now accepted as representative of the glenoid tract. 3D CT analysis using the so-called PICO method has been verified as an accurate and reliable technique to quantify bone loss. Using a perfect circle based on the intact posterior-inferior glenoid surface, the normal width of the glenoid is calculated, represented here by the red line. This is multiplied by 0.83 to give the uninjured glenoid tract value. Glenoid bone loss, as represented by the green line, is then subtracted from this value to give the final glenoid tract. This is then compared with the Hill-Sachs interval to determine if the lesion is on or off track. Our aims were first to quantify the pattern of glenohumeral bone loss in patients with anterior shoulder instability undergoing Latarjet, and secondly, to determine the influence of this pattern of bone loss on patient-reported functional outcomes. 161 patients were treated with open Latarjet procedure between 2006 and 2015. This includes 118 primary procedures and 43 as a revision procedure following failed soft tissue stabilization. The indications for Latarjet were evidence of significant glenoid bone loss measuring more than 20%, arthroscopic evidence of an engaging Hill-Sachs lesion with the arm in 90 degrees of abduction and external rotation, or failure of a previous open or arthroscopic soft tissue stabilization procedure for recurrent anterior traumatic instability. All patients were treated by a single surgeon using a standardized technique and post-operative routine. Functional outcome was measured using the Western Ontario Instability Index, or WOSI, and the Quick Dash score at a mean of 4.7 years post-operatively. The median Hill-Sachs interval size was 17.6 millimeters in primary procedures and 18.99 in revisions. The glenoid bone loss percentage was 9.8 and 7.35% respectively. There was no significant difference in glenoid tract, with 29% of primary procedures being off track and 42% of revision procedures being off track, a p-value of 0.12. The CT scans were reviewed by 2 orthopaedic registrars with a mean duration between the CT and Latarjet procedure of 6.2 months. There was substantial inter-observer agreement with a kappa value of 0.79 for glenoid tract status. There was excellent reliability for measurements of Hill-Sachs size and glenoid bone loss with intraclass coefficients of 0.93 and 0.92. On-track and off-track status did not significantly influence patient-reported outcomes. On-track shoulders gave a median WOSI score of 264 compared with 246 in off-track with a p-value of 0.73. Both groups had the same median Quick Dash score of 2.3 with a p of 0.7. Subjective instability was not influenced by any of degree of bone loss.
1 minute to go.
Thank you. Size of Hill-Sachs interval, or whether the lesion was on track or off track. In conclusion, the functional outcome and rate of recurrent instability following the Latarjet procedure do not appear to be influenced by the extent or the pattern of glenohumeral bone loss. The presence of an on-track Hill-Sachs lesion does not exclude the presence of a clinically engaging Hill-Sachs lesion. Thank you very much. And any questions?
Yeah, no, thanks, Matthew. That's interesting. I was intrigued a wee bit about the, just the selection criteria for patients having Lattershey's. I think was it for the primaries, only 29% had an off-track lesion to start with.
Yeah, I mean, that was something that we had expected that value to be higher when we first looked at it. Obviously, the glenoid tract concept hadn't been developed when this patient cohort began. And about a third of the patients didn't have any glenoid loss whatsoever. So we were quite surprised to see that fewer patients did have an off-track lesion. Yeah.
So I suppose I'm just wondering that, if the Lattershey's were looked at within that group of the people who had the off-track lesions, would it give maybe a different outcome? Just thinking out loud here, but
yeah, I mean, when we looked at the proms from just the ones that were off track, they all had similar outcomes, regardless of whether they were off track or on track.
Nick.
Yeah, it's just Kapil Kumar in Aberdeen's asked if the mean glenoid bone loss was only 9% with on-track lesions. Do you think there was surgical overkill? Could these have been dealt with just with soft tissue procedures?
I think the indications in the fact that every patient before undergoing Lattershey had arthroscopy to confirm that they were clinically engaging and that the joint was subluxing was the reassuring factor for proceeding with the Lattershey. And so even though there were patients that CT analysis suggested were on track, actually the arthroscopic examination did suggest that they were still subluxing.
Okay, no, thanks. I think we'll stop the questions for that one there. I see we've actually just got Murtada back. I think David Skipsey, I'm going to stop your presentation for a second until I just want to give Murtada a chance for his conclusion slide, because we lost it with some connection issues. I'll share it from my end, just if I can get this going. Right, there we are. So are you back with us? Oh God.
Yes, I'm back.
Great, fantastic. Let me just get to your conclusion slide. So why don't you go through your conclusions again?
Yes. So in conclusion, we report a novel method of autologous MSCs implantation to stimulate fracture healing. Local injection of the autologous fat MSCs into the fracture site resulted in a robust union in all the TPDs with statistically significant greater amount of callus, and xenogenic bone marrow and fat-derived MSCs have previously been shown to have similar effects by one of my colleagues. We show here that autologous MSCs were significantly better than the xenogenic MSCs at producing union. Thanks for your attention, and then I'm happy for any questions.
Thank you. There was just one question from Samantha Downey, who's thanked you for your interesting talk. Did you use blinding when assessing union in terms of the rust score and callus index?
Yes, sure. I blinded these ones, and it was a blinded evaluation of all these indexes.
Okay. Thanks very much, and I'm glad we were able to get you back there just to answer that question. Great. So last but not least is David Skipsey from Aberdeen with radioisometric analysis of the stemless humeral component in total shoulder arthroplasty implant stability under load. On you go, David.
Thanks. Hello, my name is David Skipsey. I'm an ST4 in the north of Scotland, and thanks very much for the opportunity to present this work. I have no personal disclosures to make. The study was part funded by Mathis. My own personal contribution included data entry, analysis, and writing the abstract and this presentation. Thanks specifically to Martin Downing, who provided the RSA analysis. Humeral stems in shoulder replacement have been getting shorter, and stemless implants are thought to better recreate the native anatomy and improve the center of rotation. They reduce bone loss both because the length is shorter, but also because they have reduced stress shielding. There's reduced risk of problematic periprosthetic fracture, and one author has found shorter operative time and reduced blood loss. Revision is theoretically easier, as it's easier to remove the stem and there's retention of the humeral bone stock. The concern with stemless implants has been their initial stability. Radiostereometric analysis is well placed to answer these questions of stability. It's a well-recognized technique that has been around for over 40 years, in which tantalum beads are inserted into the bone at the time of surgery, and then 2 stereometric x-rays are taken at the same time. This allows computer software then to calculate the position in space relative to each other, and the marker's position relative to the center of the humeral head. The aims of this study were to examine the stability of the stemless humeral implant by measuring implant migration via standard RSA, but also movement of the implant in the loaded shoulder. This is a prospective study of 15 patients who had primary osteoarthritis and were between 50 and 75 years of age. The shoulder replacement was undertaken by one of 2 fellowship-trained shoulder surgeons. The implants used were these listed, which specifically included a finished stemless implant. The patients had standard RSA, so that's unloaded RSA completed at discharge, 6 weeks, 3, 6, 12, and 24 months postoperatively. And the loaded RSA, which included a 12 Newton abduction force, was completed at 3 months onward. The precision measurements were undertaken at 3 months via a double examination. 15 patients were included, with the majority of the patients being female and a mean age of 67 years. This table shows the 95% confidence intervals for the standard and the loaded RSA, and it shows precision. So even in the total point motions, that's all 3 planes summated together to 1/10 of a millimeter. Migration. This graph illustrates the total point motion. Again, that's the total migration of all 3 axes added together. And as you can see, most patients had less than 0.2 millimeters of migration over the 2 years. Importantly, the migration was stabilizing for most patients except patient 11 and 2. Patient 11 had some migration, and as did patients 13 and 6, who had movement mainly in a lateral direction. These graphs illustrate the 2 main axes of interest. So the graph on the right shows the medial to lateral axis and shows that most patients migrated in a lateral direction, which could be due to slight subsidence. The one on the left shows the vertical axis and that most patients had some migration in a superior direction. Importantly, the mean rate of migration per 3-month period decreased from 0.45 millimeters per 3 months to 0.02 millimeters. This graph illustrates the total point motion of the induced movement under load. So that's the total movement in all axes when a load is applied. This appears to peak at 26 weeks, but there's no pattern to this movement, no pattern in the direction of this movement, sorry. And importantly, at the 2-year mark, only 3 patients had inducible movement under load. So in conclusion, we've shown it's possible to measure migration of the humeral components to a high level of accuracy with RSA. Migration and induced movement was low, implying initial stability of the stemless humeral component. We've shown that induced movement under load is measurable, which is a novel finding, and that migration of the stemless implant tended to be in a superior lateral direction. Thanks very much.
Thank you. Have you got any plans to make sort of comparisons between this and a stemmed implant and just see how they work under load?
No, I think that would be so this is sort of a pilot study, so I think that would be one of the next things to do. I've seen RCT protocols online elsewhere of people planning to do that as well. Sorry, to clinical outcomes, so it'd be certainly something to do.
Professor Howie has a question for you. What is the definition or your definition of a stem. Surely this is a short stem.
Well, I suppose you could argue about the length, but I think it's I would argue. Well, it has a stem, yes, but I think the short stems are the ones sort of where you have filling of the proximal metaphysis and entering the diaphysis, and I would argue that this is a stemless implant.
I think Prof's being unfair. Like even the classic shoulder resurfacing had a tiny wee stem. David Cairns has just come up with a question, Nick.
Yes. Professor Howie's just... you can't see that. A stem is a stem. A stem is a stem. He's maintaining. You can...
Well, I suppose the shoulder community would have to all agree on the terminology of very short stem.
Oh, the questions have gone wild with the
next year you can find Prof Howie at the bar and continue that one. Right, David Cairns in Aberdeen has sensibly contributed that this is now internationally accepted nomenclature, so he saved you there. And David could join Colin in the bar next year. Right, Kapil Kumar. Yeah, we're all saying the same thing. I think that's probably a sign that we're done with papers for the afternoon.
Yes. So thanks very much to all those presenters. I think that's been a great session, and it's been the inaugural virtual registrar presentation, and everybody's coped very well with the technology, so that's fantastic. What will happen at the end is that the markers will reconvene in a separate Zoom room, and then we'll send out an email later to announce the winners, and we'll also put it on the SCOT website. So thanks very much. I think I'll hand back to you for the final section then.
Well, thank you very much. Thanks to all the presenters too. That was some excellent work being presented today, and as Paul had said at the start, some high quality stuff despite everything that's been going on. This is usually the time in the program where we would leave the room and combine marks and then come back in. So we had originally thought of doing that and using the time and the fact that there are hopefully still a lot of trainees on the webinar to open a session on Q&A and discussion about training. I think at the moment, hopefully there are still, at least most of the TPDs are still on the webinar.
I'd say it's very impressive. We've still got 66 attendees, which far surpasses what we normally have on by the end of the afternoon.
That's right, and we know who you are as well.
We know exactly who you are.
That's right. In fact, did you want to say, Paul, that attendees will get an email confirming attendance, and that's for
Yep. So the people who've joined us today will get an email tomorrow from the system. So that will be your sort of proof of attendance for your portfolios, etc. And I've put in it what the various talks were, so you can use that. And the people who didn't attend, they'll get a similar email, but we'll say, well, try and attend next time.
What I wondered if we could do is, and I'm delighted to see that Professor Turner is still with us as well, is to see if it might be possible to have the TPDs join the panel, perhaps, for this discussion, those who are still here, and possibly Donald Campbell and Phil Walmsley. Donald obviously is in the SAC, and Phil with his past experience of SAC, and really open this up to trainees to ask us questions. So therefore you've got, I think, quite a good selection of people with experience of training and where we are with training in the country. I think to open the session, really, as you've heard already, we are aware of the challenges that exist to provide you with surgical training, operative training at the moment, and there is no substitute then to get that back, but also to maximize the opportunities that there are out there. And that's why I alluded to the private sector work, which is going on to some extent, that is now accessible to trainees. There is also obviously a need to think smartly about doubling up and sharing opportunities, but we're also aware that consultants are rusty, and consultants are wanting that experience and wanting to get the operative work too, and they will be doubling up for cases, although it may be the more complex ones. So that's a pressure pulling in the other direction. From NES's point of view, we saw beginning of August as an attempt to return to normality, in the sense that there should be no one still on redeployment out of orthopaedics. All trainees should now be back, core trainees, etc. We now are approving study leave again, and so that should be accessible, albeit we accept that courses are not what they were previously at the moment. And we hope very much, I mean, there have been some very impressive examples around the country of teaching programs and how indeed they were enhanced perhaps during COVID due to accessibility through Zoom and similar platforms. And I alluded to that earlier. So I think what we'd like to do is please submit questions and comments to us all while we're here, and take the chance to ask us questions. But while you're thinking of what to ask, perhaps maybe I could go to you first, Phil, if I may, Prof. Turner, and say, and just to ask your own view on what can we do over the next 6 months to try and help our trainees catch up.
Yeah, it's been exercising us at the BOA. It's a really serious issue. We haven't really got a handle yet just on how bad the impact has been. As far as I'm aware, the SAC are trying to put some figures together so that we don't just working on impressions that things have gone badly, but we really know that they've gone badly and how long they've gone badly. And that should be available in the next week or so, I'm given to understand. Then at least we've got a baseline to go from. From my own experience, I think that the trauma side of it seems to have gone pretty well. I think our trainees, certainly in the Northwest, have managed to keep up with the trauma input without too much difficulty. So it really is the elective work, and it's at both ends, those at the fellowship end and those who are early on in trying to get the basic arthroplasty experience that are struggling. So I think we've got the first thing, I think you've done it really well, is to use private facilities and to get them to agree. That's the biggest problem we've got on the England side, is getting that agreement. And where I am, the Spire Hospital simply will not allow it. They just say that they will not accept it, and they come up with totally spurious reasons for doing it. But the BMI hospital, which is 3 miles down the road, fine, they will go for it. So there's no consistency in what we're getting either centrally or from the individual hospitals. Every opportunity has to be taken to train and give practical experience. We're certainly promoting as much as possible to use simulation, but simulation can only go so far. And I think it's the real practical experience of doing the operation is what counts. So every single case that every trainer does, you've got to think, can the trainee do this, or at least do part of it? It's got to be a new mindset, a new mentality of how you go about doing this. There's no simple answer. Hopefully, as we come out the other side of winter and things move on, we can really try and make the best possible opportunity for everyone to catch up. But I've got no great solution. But what I do hope is that we're going to have some numbers that we can really look at.
Yes, I think that's very valuable if we start to understand our logbooks better and what's been happening in reality. I think what was made clear at our committee meeting earlier as well, Donald reported back that the SAC has no intention of changing the indicative numbers or shifting the goalposts in terms of what we expect our trainees to do. And that you can understand the sense of that, but it sets out the challenge for us. And I'd also mentioned that we are anticipating at the deanery to continue using type 10 outcomes at ARCP, which are the no fault, either extension or not outcomes for training for up to 2 years at least. So we recognise the impact of what's happened will go on for a while, and that we will try our very best through the deanery to give the trainees the time they need. It may be frustrating that it's going to take a bit longer. That might be the reality for some, but I think we will be very much, as I said, the competency-based training is now what we must look at. Can I open this to other members of the panel for their thoughts and comments? Perhaps TPDs could, there's Capel's raised his hand, so you go first, Capel.
Thanks, Al. Just a couple of points which we discussed at the STB meeting as well, and you referred to the 10 extensions or 10 outcomes. I perceive that there are a few issues there. Of course, apart from the most obvious one where people's training times will be increased, it doesn't, the the NES has to think about what's the impact on workforce planning, because if you're going to have 3 trainees extra staying in the system because they can't get their CCT because they haven't got their numbers, what will happen to the recruitment at the other end? Will we have to restrict the numbers there? But the other issue is the new certification guidelines, which now expect trainees to do 70% of the operating as first surgeon. How is that going to be feasible over the next 2 years, where the best case scenario is that we will still be working between 60 to 80% of our efficiency in theater over the next whatever time, and the sort of the slow speed at which we are resuming elective activity. And I don't think I've got the answer. Maybe other people can think about what we're going to do, but the workforce planning is, I think, must be a concern.
I think you're right, Kapil. I don't think there'll be a lots of money sloshing around to create additional numbers. I mean, there's been a lot of money spent over COVID. From the point of view of your second point, you know, I think we can put that around as well. Put that around the panel. What people think. Phil, you've got your hand raised.
Yeah, I was actually it was a separate point I was going to raise. Really was about the problem with this is that in giving advice to everyone is that it's so heterogeneous, because it depends to a certain extent what year in training you are and what you've done so far in terms of different subspecialties. I think trauma is obviously continuing unabated, but it's the elective stuff, and that will vary not just on what you've done, but also where you work. As we were discussing this morning, different units are coming on stream with their elective activity at different rates. So it's a very it's almost shifting sand. Some will be affected a little bit, some a lot by this. And just a note on simulation. Simulation obviously varies from high fidelity, very expensive to run versus very simple things. And I agree with Phil Turner that it'll help bridge a gap, but it can't replace everything. Although it may help improve the quality of the teaching you get in theatre if you're more familiar with the procedure. And again, you then run into the problems of inequalities of access across the different regions. I'm really putting points forward. There are the solutions are much more difficult for this. But like you, I think that some of our trainees will end up being extended through no fault of their own because of just the timing of when they came through the system. As regards the recruitment issue, like you, I work for NES, and I can't see there being a huge amount of money to pump prime posts. So I suspect that may have effect on recruitment, and then that creates a back pressure further down the line with people aspiring to come onto the system. And I suspect the same will be true south of the border as well. But obviously, Phil will know more about that than I.
Yeah, I mean, I think, well, two things. Firstly, I think, Kapil, your question about 70% rule, first operator 70% rule, I do wonder, maybe hope if there might be some flexibility there. I don't know if, Professor Turner, you think there would be, but you know, that will be really hard to achieve in the next 12 months. But yes, in terms of workforce, I'm anxious about that. It goes hand in hand with trying to expand workforce for electric treatment centres and different ways of working. I think there's a recognition at NES and HEE that the surgical specialties have been hit particularly hard by COVID. And our lead dean, Adam Hill, is doing, you know, knows that, recognises that, and is advocating for it. But you know, what else to add? I think, Sam, you put your hand up. What were you?
I think at the moment we can say all we want. We're going to keep up our numbers game. We're going to maintain what that is. But in a few years' time, if we have no workforce coming off the top and no numbers available at the bottom, that's going to actually just be completely non-viable. So I think we're going to have to look at ways of, we're already moving towards competency-based training, but really looking in detail at how well people are being taught on each list, prioritizing those trainers who are really training very well. Because you can say supervised trainer scrub versus really high quality training during a list, and making sure that people are being placed at the places that give them the best training, and then assessing their improvement really in a really detailed way, rather than just saying, well, I did this many hips and I got supervised trainer scrubbed. And all right, we have our categories at the moment, but I think we're going to really have to tighten up how well we assess the training and how well we assess the progress, and base it on that rather than numbers, because it's going to be everyone in the country, and it's a non-viable situation to say, well, we'll just delay a whole load of them.
It's interesting. I mean, I think the numbers are the challenge. As I said, I'm not sure that the numbers will be relaxed, but the multi-consultant report facility might be something that helps us a little bit there, and being able to evaluate our trainees a bit more subjectively. That I agree with you, Sam. I think we need some more subtlety around that. The other thing I was going to raise is the notion of our trainees going, and it's been raised already, going where the activity is. You know, we have this regional variation. I know Evan, I see Evan, you're on the call, a West of Scotland TPD. You know, trying to get a little bit more access for trainees, perhaps at the Jubilee, that kind of thing. We need to make sure our trainees are going where the work is. And we maybe need to think a bit more flexibly about that and moving our trainees around a little bit more as trainers now to make that happen. Evan, do you have anything on that?
Yeah, myself and Bryn have been exploring the possibilities. It's never going to be a high volume solution because of if you pluck patients away, doctors away from service, then service always protests, and Bryn has been trying to do this for over 10 years now. But we're maybe a bit further ahead in that we've got provisional agreement from the rota consultants at the Queen Elizabeth, because they think their middle grade rota can deal with it, and it would be on a similar basis where they would do trauma at the Queen Elizabeth but do elective stuff at the Jubilee. But as I say, that's not a high volume solution. That's maybe going to help one or two trainees. The single biggest, I mean, I've got 64 trainees, and about 24 of them were on outcome 10.1 simply through loss of surgical volume acutely because of COVID. And that will probably go to something like 2/3 of the rotation this time next year. The biggest barrier, I think, is going to be the 70% number. I think we can get indicative numbers, and I think we can get the total volume of 1,800 in most cases, perhaps with some small extensions. But I think if it is mandated that the 70% first surgeon has to continue, then I think the vast majority of the next 3 years are going to need extended. So I think if there could be any further derogations from the SAC, that is the single one that I think would help the most, and would not really be a dumbing down of things, considering that for the last 5-6 years there has been no requirement for 70%, so it's parity with what currently exists.
I think that's a very good point, Evan, and you know, I think that would be a message we'd like to take back through our STB, and also you know, if we can convey it to the SA. It's a new thing, and it's a bit arbitrary, isn't it? Just because you're your first operator, it doesn't mean, it goes to Sam's point, it doesn't necessarily got the quality of training from that opportunity. It's much more important to have an evaluation of what you've done than to just claim a first operator case. And so I've always felt slightly uncomfortable about the notion in the first place. I'm showing my bias, but you know, I think you're right. I think there seems to be a view around this panel that 70% rule is an issue that we might wish to challenge.
Well, I think it's just a bit incongruous, considering we were a bit, you know, now we should have the competency-based curriculum, yet there's now a set of numbers of 70%, and I understand the requirement, the reasoning behind it, but you've got a whole curriculum now geared up, or potentially geared up to competency-based assessment, yet a CCT guideline that has a strict number regardless of your competency assessment. So I think there has to, I would hope there could be some sort of meeting in the middle regarding that to help things over the next few years.
Yeah. The other thing that I guess, I mean, we're very focused for obvious reasons on operative thing is outpatient experience as well. We mustn't lose sight of that. And I know many boards have got a fair decent volume of that going again, but you know, can I ask, are you getting our trainees involved in near-me consultations, that kind of thing? The face-to-face opportunities that there are they accessing those, or are the trainees still very much focused on clinical ward work and theatres when the opportunities are there? I'm just interested to hear around the country. Perhaps we'll go up to David first, up north. David, how are your trainees accessing near-me or outpatient stuff?
Yeah, I mean, certainly we're very slowly getting them reintroduced to that. If you don't mind, there was just something I was going to mention, a couple of points that I'm concerned about. I agree with everything that's been said so far, but the concerns I have about the disproportionate effect for the early years trainees, particularly the ones who have been redeployed as a result of COVID, compared to, you know, the ST5s and higher grades. And, you know, my real concern about a potential second wave is if that were to happen, a redeployment a second time, you know, I think they would really be in a very, very difficult position. And I guess in a similar vein, trainees who are prior to COVID were in difficulty. I'm really concerned about the effect that COVID and the outcome 10.3s, for example, will have on their progress. It's all too easy to see how they may just be shuttled through the system and everything attributed to COVID. So those are the things that really trouble me most. So I know I've not really quite answered your question, Al, but you know, I just wanted to make those points.
Good points, David. I would say on your first point about redeployment, there was as you know, when redeployment happened, the autonomy was given over to the DMEs in the boards, and they were told to redeploy where you need to redeploy, and NES kind of took a step back from that, and there was a realization that we wouldn't do that again, because we didn't have the control to get the trainees back again that we felt we should have retained. So I think if there is to be any further redeployment going on, I think NES will be much more proactive. I see Phil nodding his head about how that happens, how we review the continued redeployment when the trainees come back, etc. Because I think it's fair to say a number of trainees, particularly our most juniors, were left on redeployment for time, perhaps more than they should have been, and their supervision wasn't what we would have hoped for. So that's the first learning point from recent discussions at NES. Okay, just going back, anyone else with trainees accessing Near Me, carrying out Near Me consultations? Phil, and Near Me is our video attend anywhere type consultation tool in Scotland. I'm not, forgive my ignorance, I don't know if it's the same tool in England.
Yeah, it's Attend Anywhere is the commonest one. A lot are done just on telephone consults rather than just purely video though, which makes it more difficult to run through with trainees. I think you're right, we've lost focus on trainees being trained how to do consultations in the new environment, because this is going to carry on, and I think you do need training in what can be done and what can't be done, and they do have to be done properly. It's a whole new skill to do it well, and you know, I think many of us are making it up as we go along with how to get the best out of these consultations, let alone training someone else how to do it. So there's some good materials out there to give a clue of how to go about it, but many of us are finding our way about making the best use of it.
Thank you very much. How about Simon, Sam or Evan, are trainees accessing any of these outpatient? I know that, Evan, we've got trainees coming to the Louisa Jordan in the west of Scotland to do some face-to-face, which is good to see.
Yeah, so we're doing face-to-face fracture clinics, and we're starting to get them into Louisa Jordan, but as far as I'm aware, they're not involved in any of the virtual stuff that's going on.
Sam?
NHS side, trainee involvement in virtual stuff. I think it would be something to improve.
I was going to say that we've started to bring in a little bit of Near Me into NHS Tayside. It's been a slow pickup, and mainly because of provision of equipment. A couple of my consultant trainer colleagues are sort of leading on the video consultation, and they certainly having their trainees sitting in with them, and they're assessing their trainees doing the video consultations, which I think is a very good model, and hopefully we'll move to it as a sort of wider population. But I think there's still fairly limited equipment, and I think some sort of subspecialties fit Near Me better than other ones. So it's several colleagues who sort of pioneering this, which are leading, and we're watching their example.
Okay. And I would love this discussion to go on and on. It's an area of particular interest for me, and I think everyone on this panel just now, but we are up against time, and it's been a long meeting for all of us. But are there any final comments or indeed questions from the trainees who are still in the webinar that you'd like to put to us, or any observations even about your experiences locally before we close? If not, then I'm afraid you've heard, we don't have a lot of solutions necessarily, but I would like to reassure our trainees that, you know, there's a lot of time being spent trying to work out solutions and to address these issues, and you know, what the challenges will be, and to make sure we grab every training opportunity that we can. And as trainees, you're well placed to identify if you think opportunities are going past that should be grabbed. Please discuss that with your TPDs. Something can be worked out, you know, and we can come up with bespoke solutions You know, we're in the business now of innovative solutions. We want to find out anything that's going on. So please, you're often the best place to come up with the ideas. So please communicate with us on that. That would be my final plea. And I think probably the final comment, if I may, for today's summer SCOT meeting. So for everyone who's still in the webinar, many thanks indeed for joining today. I think it's been a great meeting, and our three speakers were fantastic. Phil, you get the prize for staying with us for the longest, and many thanks to you. But to all our contributors and to the trainees who presented their work today, thank you for joining, and fingers firmly crossed that we can meet in person in Crieff for our Burns night at the end of January. Let's hope so. I think we could all do with it. So thank you all, and have a good weekend.